have our analyst here, we have our other staff members, and it looks like we've made the 7 threshold. Good morning and welcome. This is today's session on the Joint Standing Committee on Health and Human Services. We'll be doing some work session efforts early, and then this afternoon get to a public hearing. There will be various members, various people in the what's referred to on our list as the attendees list who may have something to contribute to all this. And we ask if, as we discuss the bill, you have something particular that you'd like to help us make our jobs easier. Then please put your hand up electronically, and we'll try and get you into the panelist role, which is where the conversation happens. So this is not a public hearing. It's a chance for the committee to discuss the value of the bill and try and improve it or decide what we want to do with it as we work our way through the list of 170 bills that we've considered and are getting closer to the end. So let's go around the horseshoe and introduce ourselves, and we'll start with Representative Zager.
Thank you, Mr. Chair. Good morning, everyone. I'm Sam Zager. I represent District 41 in Portland.
Representative Lemelin.
Good morning. I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Senator Baldacci.
Good morning. I'm Joe Baldacci. I represent Senate District 9, which is the city of Bangor and the town of Herman. Thank you.
And Representative Connor, Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
And Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescate.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. Good morning. Thank you for being here with us today. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton. I'm honored to represent the folks in Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We are ably supported and facilitated by our staff. So we'll start with Ms. Broom.
Hi, I'm Anna Broom. I'm one of the legislative analysts for the Health and Human Services Committee, and I work in the Nonpartisan Office of Policy and Legal Analysis.
And Ms. Withy.
Good morning. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance today, you can email me at hhs@legislature.maine.gov.
Carrie is our technical wizard and will help you get connected if you're having any trouble at all. She's a great resource. So we'll be considering the bills in the order in which they're published, with one exception. We'll start with 1629, do 1385, then 968, then 1586. The bill 1427 has been moved to Thursday, and then we'll finish the rest of the list. If you're listening but would like to also watch, you should know about our YouTube channel. You can go to legislature.maine.gov, look for committees. The drop down will get you to Health and Human Services. And in the upper right-hand corner, there's a link to click on to go to YouTube, where all of our prior sessions have been recorded and where this one will reside as it is after it's been recorded, which is happening now. Any other issues? Oh, we've been joined. Any other issues to deal with before we proceed? Not seeing any. We'll start with consideration of LD 629.
Okay, hopefully you can see that. So LD 629 is a resolve to establish the task force to study improving safety and provide protection from violence for healthcare workers in hospitals and mental health care providers. The resolve establishes the task force to study improving safety and provide protection from violence for healthcare workers in hospitals and mental health providers. There was a request from the sponsor to establish the task force with 13 members that would review the process by which criminal law cases may be brought related to incidents of violence in hospitals, in particular where patients or individuals related to patients assault hospital or medical staff. The report would still be due on December the 1st for presentation to the second regular session of the legislature. So you heard that the sponsor was requesting an amendment, and you also had some testimony from a number of organizations, including Northern Light, Maine Health, and the Maine Hospital Association supporting the amendment. They were opposed to the original bill. They are looking for a pathway where hospitals can report the crime on behalf of an employee. It's not clear if the hospital can represent the interests of the employee, what the options are for hospitals, and what information is needed for DAs to prosecute. And you did hear about what they already have in place in their hospitals. You heard from the Alliance that they need a process to assess the person involved, and if they're in acute mental health crisis, a bad substance reaction, or creating a dangerous situation due to anger, because this would affect the response to that person's situation. And you heard some concerns about membership, for example, the Consumer Council, and a recipient of mental health services, an organization that represents patients. So some requests for that inclusion. So the drafting issues are concentrated mostly on, well, partly, I guess both pieces of it actually, but partly on the amendment. There's no emergency preamble on this, so the study wouldn't be able to begin until 90 days after adjournment. Legislative studies usually have an emergency preamble because of the time it takes to make appointments. So that's a little unusual. It's also unusual to not have a specific committee or committees receiving the report. This is drafted for presentation to the second regular session of the 130th legislature. I'm not really seen that before. If you are adding a committee to receive the report, it may depend on what you decide is the contents of the study. For example, the amendment is concentrated on criminal law cases, and that's not typically in this committee's jurisdiction. The amendment doesn't conform to Joint Rule 353, which you know about the joint rules. That requires a majority of legislators. There are plenty of studies that don't conform to 353. It just means that the Legislative Council or the study table can choose to amend them to make them conform. So it's always a risk you take if you send a non-conforming study to the study table. This relates to the amendment. The legislature can't appoint members of the judicial branch. I looked for a couple of examples for how we usually draft that, and there are a couple of options. One is to invite the Chief Justice of the Supreme Judicial Court to designate a member of the judicial branch to serve as a member. And another option is members appointed by the Chief Justice of the Supreme Judicial Court. And I just put the citations for that because they would be largely familiar to you, I think. And the legislature could appoint district attorneys, but they are all also officers of the court, so it might be appropriate to do the same for appointing DAs as the judicial branch members if you want to move forward with this. I don't know if the language of the duties is clear enough. It could be a bit more specific if you want to move forward with this. For example, you could include things like the response of hospital staff to assaults and violence, response of law enforcement to those assaults and violence, and response of prosecutors to cases of assaults and violence referred to them, and the disposition of prosecuted cases. I do know that you have some of the folks from Maine Health and the Maine Hospital Association in the waiting room if you are interested in fleshing out those duties. We haven't yet received the fiscal note from OFPR, but this is a legislative study, so that means it used legislative resources because we always pay legislators and we have to do that. So it would go to the study table. There are other reasons it goes to the study table too, but that's just the first one. I'm quite proud of the fact I was able to paste this into this document. I also learned by accident while I was doing this how Erin managed to scribble on her forms the other day when I was trying to figure out how to do something. So I'm feeling quite proud about that too. I don't want to demonstrate that I have figured out how to do it, but I have. Anyway, so this is the amendment that the sponsor was requesting. So you can see the task force actually, it says 15, but it's actually 13 because he has only one member of the Senate and 2 members of the House, which is definitely not a majority, but is also lower than usual because you don't have, you can't have senators from both sides with a number that small. And he is numbers 3 and 4, I believe, are right out of the original bill, but then you can see he's included all the law enforcement, district attorneys, and the judiciary. And then this is the duties that I was talking about that seems a little bit in need of fleshing out, the processes by which criminal law cases may be brought related to incidents of violence in hospitals, the possibilities that I had up here for what how it could be. This I reached out to the staff of the Criminal Justice Committee because I don't do criminal law for some ideas, and that's where those come from. And then at the very bottom is just the joint rules to show the majority of legislative studies in no more than 13. I did put the no more than 13 in there because if you were going to increase legislators and keep the rest, you would run into that problem as well.
Any response from the committee before we go to the sponsor about that analysis? Any questions? Representative Perry.
Yeah, I guess my question is how prevalent is this throughout the state? And is this something that we need this kind of a response to?
Okay, we have testimony that says it's an issue and that it's an unresolved issue as to how to proceed. I don't know if I don't know if that data gets compiled because a lot of those don't end up as cases because the individual who's been assaulted decides not to bring the case. So any results we have are probably significantly underreported. Other than a trend as seen from the hospital perspective, I think is of a steady increase. So we'll put that aside for right now and come back to that. Representative Zager?
Thank you, Mr. Chair. I don't know if I have so much of a question as just something that what Anna just presented makes me wonder. This whole thing about the Committee of Jurisdiction. She pointed out that the place in statute that this refers to is not traditionally the jurisdiction of this committee, and so if there were a crime, if there was something about a crime that occurred in the Maine woods, would the ENR hear that, or would that go before criminal justice? I'm just not sure how these things sort out. And so as we contemplate where a report back might be to, that seems like a really key piece of who has jurisdiction.
And it could be that the report back comes to 2 committees, but the Committee of Jurisdiction gets the responsibility for taking next steps. Is it right? Am I right about that, Anna? There's no reason we couldn't hear a report back on this in HHS, but still have it fall to judiciary to do any lawmaking related to the outcome of the conversation.
Right. My understanding is it's never been entirely clear, but in the last couple of years, the practice has been if a report went to 2 committees, they could both report out a bill. I don't know if I'll get struck down for saying that out loud on the YouTube, but the last couple of years that has been sort of the general practice, but it's not entirely clear. But we saw that with 1602, which is the mental health study that went to 4 committees, and that was how it was interpreted then. But yes, you could make it due to 2 committees, absolutely.
Okay. And then we can have the conversation about which is really the Committee of Oversight and appropriate. I mean, part of these assignments happen because of keywords in the title of the bill. And in this case, it was hospitals. And judiciary doesn't usually have anything to do, or doesn't have much to do with that. So that's why it ended up with us. Any other questions from the committee or comments? Representative Reisman has joined us. Welcome, sir. Good to see you.
Good morning, Mr. Chair. Thank you. I can answer very little because the experts are also in the waiting room. But in terms of the changes that might be made to the bill, they sound more like technical changes than substantial changes. So I'm willing to work with the committee on any changes they feel are necessary.
So Representative Reisman, one of the questions was asked was about prevalence. Do you have a sense of that, or how did this first come to you as an issue of concern?
It came to me as an issue of concern by a staff member of an organization, saying that with the conditions that are out there these days, the environment is ripe for some sort of problem, and we can't substantiate that because a lot of this is confidential information.
Sure. Okay, thank you. So I think there's a number of different issues. Let's start with the membership. Are folks okay with amended version of the membership of a task force? Let's start with the bigger picture. Is there general support in the committee for the concept of pursuing this issue using a task force? Broad question. I'm seeing some heads up. Senator Moore.
I just noticed that Jeff Austin has joined us from the waiting room. Maybe he has a comment he'd like to share with us before we proceed.
Thank you for noticing that. I didn't see that. Welcome, Mr. Austin.
Thank you, Senator Claxton. I don't want to interrupt the flow of your conversation. I'm here and available to you. I will say this is a big issue for our members, and our original goal with the amendment is that I think many of our members take an understandable approach to this situation, that if the victim doesn't want to pursue the case, they sort of respect that and don't pursue it. Yet there are collateral victims anytime there's an assault in a public emergency room. And they're interested in understanding what their options are to pursue cases when the victim, for whatever reason, says, oh, it's just part of the job. I mean, nurses take on so much, and sometimes they say, oh, it's just part of the job. And I think increasingly administrators are like, no, this is not part of the job. We may want to pursue the case. There's no technical, legal need for the victim to participate. So we know theoretically, law enforcement and district attorneys could proceed without the cooperation of the victim. We understand that technically to be true. But what we need is a better understanding from those parties, really realistically in the real world. When will you, as the law enforcement and DA, when will you bring a case without the victim? What do you need from us? What are the circumstances in which we can be successful in prosecuting a case? So we kind of need a conversation with them. As this issue has developed, we've heard about other sort of distinctions from one DA to another in how they view just the hospital violence setting. There's already enhanced penalties for violence in an emergency room, but how DAs approach that is very different. Some say it actually has to be the hands-on patient assaulting the nurse, as opposed to maybe the family member in the hallway. So we think there's a number of things that could be fleshed out from that conversation. Two results could emerge. One is we just amend our policies, internal policies on how we handle violence, and you don't need to make any changes to your laws. That's one potential outcome. And the second is maybe we also do need some changes to laws, whether they're in Title 22 in your jurisdiction or the criminal statute 17A or whatever, and somebody else's jurisdiction. We can figure that out after the conversations have occurred. So I appreciate you letting me jump in, but that's kind of where our mindset is on this issue for this particular bill. Thank you.
Thank you. Thank you for that. Senator Baldacci?
Thank you, Mr. Chairman. I totally support this committee and this effort to deter this kind of behavior, but I think just parenthetically, it's almost going to be impossible to prosecute a case without the victim. So they may have to look at both criminal and civil avenues, but I totally support this effort so that we can all learn more and maybe find some solutions. Thank you, Mr. Chairman.
Great, thank you. Senator Moore.
Yes, thank you, Senator Claxton. I guess one of my questions would be is, do we really need to have members of the legislature on this task force? Because that kind of shoves it into a different situation as far as having to go to the study table and, you know, the cost of that and so forth. I'm just questioning, do we really need legislators on there?
Any response to that? So Anna, as soon as we include legislators, does that get us support for the committee's work in the form of designating resources for a clerk or coordinator?
I think I understand your question. If it's a legislative study, it's
Yeah.
most likely to be staffed by legislative council, not necessarily. You saw 1602 was staffed by the department, for example, and the one that you chaired on children's mental health was also staffed by the department.
Right.
It does get it to the study table, but if
Yeah.
you decided that you wanted a stakeholder group, task force, whatever, that doesn't have legislators on it, you can do that, but you would need to determine who was going to convene it and who was going to staff it. But you absolutely could do that.
Right. Okay. Does that answer your question, Senator Moore? Okay. And the issue of who would convene it is a little complicated, unless it's DHHS and maybe licensing. Representative Zager.
I think Senator Moore brings up a good question. Thank you, Mr. Chair. I'm wondering if this kind of reminds me of the palliative care issue that this committee heard. That was we basically just asked some people who were kind of closest to the issue to think about it and report back to this committee, and this committee had it was empowered to advance legislation from that. That I don't believe had any legislators affiliated with it, and it seemed to work well as a mechanism.
Any thoughts about that?
Can I just add that palliative council is in statute? That's why you could ask them to do that. But it didn't have legislators, which I think your point. But the reason you could ask them to do that, you actually did that by letter, but you could have asked them to do that by resolve if you wanted to, because they're in statute. So you would need some kind of equivalent here. But that was actually done by a letter.
It's just the same way we did with the long-term care ombudsman and a study that they'll be doing, that she'll be doing with us. Let's back to the basics just briefly. It sounds like there's support for continuing to pursue this and trying to figure out a path forward from the committee. I see some head nodding. So who do we think should convene this group? Are we asking DHHS to do it? And who might be the convener? And we'll bring in Molly to see if she wants to volunteer. Just for the record, Molly's allergic to task forces. Welcome, Ms. Bogart. The question's been raised about who might be a convener on this. Does this sound like something that you think the department could support, or is this outside of your roundhouse?
Good morning. I'm Molly Bogart, Director of Government Relations for DHHS. And allergies aside, I didn't hear a role for DHHS in this conversation so far. And so it does feel like that would be the wrong convener if this is around criminal penalties and, hospital policy.
Sure.
It feels like a different place would be more appropriate.
Different animal. Mr. Austin.
Yes, I think I would suggest a judicial branch. They convened on the legislature's behalf a study group maybe 5 years ago on the blue paper process, and it was very successful. I participated in it. I would, out of respect to the judicial branch, I'd reach out to Julie Finn, who's their liaison, their Molly, and is always very responsive. I did reach out to her on this bill. a while ago, and she had no concerns with it, although it did not directly ask the judicial branch to convene the group. But that as a convener brings weight, I think, among the DA, prosecutorial, law enforcement community to get everybody at the table to really figure this out. So that would be a suggestion from us. But Julie's very responsive, I think, as you know.
Yes. Yes. So that will be asked of the judiciary branch to be the convener and to provide staffing, which is, so it's going to generate a fiscal note. Yes, Anna.
I just, I'm hoping that Jeff can send me what that study was, because I don't think we can tell the judicial branch to do something. So I'd be interested to see the language on how that was drafted, because I don't know how to do that right now. Which doesn't mean I can't figure it out, but I can't figure it out in a minute.
Right. And I think my understanding was it'd probably be in the form of a request, which is different than a
Right.
tell. Yeah. Okay. So that also raises the issue of staffing. So that should go to Julie too, about whether that's something they think they could manage. We might as well know about that before we commit one to a pathway. How about the language as Senator Moore?
Thank you, Senator Claxton. I'm just wondering, I know we don't have much time, but I'm wondering if we should at least table it for today, so that we can run that by Julie and make sure before we start passing something that, and changing the words and so forth. It's just a thought.
And I agree. And I think if we can iron out a couple other specifics about our ask before we table it, that would make some sense. And then we can bring it back. So one of the questions was about the judicial appointment and the DAs. Are people comfortable with the language that Anna proposed as designated by the attorney? Yeah. So we're comfortable changing that language to put the power in the judiciary side of things. Yes, Representative Zager.
Thank you, Mr. Chair. I'm liking the way this is headed. I'm just wondering if there's a reason why we're focused on just on hospitals as the site of where healthcare workers could be subject to these this kind of incidents.
Representative Reisman, how do you feel about broadening the scope to include other?
Well, my original, thank you, Mr. Chairman. My original proposal was to include mental health facilities, but
So
the people who stepped up to the plate of the hospital. So I'm not sure how we would incorporate other facilities in there, but I'm all for it.
Okay, so this would include healthcare facilities more broadly than just hospitals, potentially. Okay, all right. How about the duties? Are folks comfortable with the amended version of the duties at this point? Though, can you share your screen against Anna? And
Yeah. So this was the part. So it currently says the process by which criminal law cases may be brought related to incidents of violence in hospitals. What I got from Jane were just as examples were to be more specific to say responsive hospital staff to assaults and violence, responsive law enforcement, responsive prosecutors, disposition. I don't want to speak for the hospitals, but that would depend on perhaps what Jeff or somebody, if that's what they're looking for, including what you're looking for. Do you want me to keep it up so you can continue to see it?
Mr. Austin, did you have a comment?
Well, just to give you, I mean, we don't oppose broadening it. I would say there's a statute on the books already for enhanced penalties for assault in the emergency room setting. Just to stretch this out a little bit more, and I apologize. How we got here is last session, we brought a bill to extend that enhanced penalty provision to assaults anywhere on campus. because the assaults on our workers are not confined to the emergency room. And we brought that bill forward to the Criminal Justice Committee, and we got crushed. And the reason we got crushed is the defense bar came forward and said, these cases in the emergency room are not being brought now. Typically, they will only somewhat consider enhanced penalties when judges are routinely bumping up against the limits in the law already. You know, if it's 365 days is the maximum sentence. If they're routinely giving out those sentences and they're frustrated and they're saying from the bench, hey, the only reason we're not giving you more time is the legislature hasn't allowed us. And so that made us look inward and like, we're seeing these assaults. Why aren't we bringing these cases? And so that prompted an internal conversation that led to, you know what, a lot of times we just sort of let the person who was punched control that decision. And now we want to explore maybe not doing that. But we don't know how realistic our chances are to bring these cases until we have some real honest conversations with the players. So that's how we got here.
Okay.
Additional background. Sorry.
Thank you. Representative Meyer, you had your hand up a minute ago.
Thank you, Mr. Chair. I was going back to the makeup of the task force now that we have decided it is not a legislative study, and just what Jeff Austin's thoughts might be on that.
Sure.
We welcome legislators at every meeting, but yeah, to avoid a fiscal note or, you know, a study table hiccup would be unfortunate until we know that we really are seeking to do legislating, which we're not sure yet. We need this conversation to move forward. We don't know if the law needs to change. If we could avoid that, but obviously we want to be respectful to the sponsor and the committee members if you think you're essential. At this stage, I don't think it's such. We need to get a lay of the land a little better and then maybe engage you, but your decision. But I don't think it's essential at this point.
And your thoughts on the makeup of the committee if we go in this direction?
I thought it was pretty good. I will say, as it was drafted, this conversation won't end for hospital administrators once we finish with the law enforcement community. Once we get feedback from them in adopting the hospital's policy, we're then going to turn to our employees and say, you know, this is what we're thinking of doing and changing our hospital policy about violence and when we're going to bring forward cases. We will engage the affected employees. Right now, we just kind of need a legal answer. You know, can we bring these cases realistically and what do they need? I mean, Senator Baldacci's right. Without the victim, it may be very difficult. What if we have, I mean, you don't fight the hypo. What if the hypothetical is that you have 100 witnesses and video evidence, you know, and we give that to the DA? Are they going to bring that forward even though the victim doesn't want to participate? So we need to get that legal question answered. Then we're going to engage with employees, but we're open to obviously your input on who should participate at this stage.
Representative Reisman, are you okay with not having legislators on this effort?
Well, mostly okay. Sometimes I believe that there are legislators who have something to contribute to a commission like this, but if it's too bulky, then I'm fine with eliminating it.
Yeah, and since these are public meetings, legislators could certainly come with their expertise as invited guests or witnesses in the process.
This is true. Yeah.
Okay. All right. Okay, so we've made some progress on membership to exclude legislators and go with the amended list. We've made progress on delegating the responsibilities to another entity. And we've made progress on who appoints some of the members, the judicial branch appointing somebody as well as a DA. And it sounds like there's some acceptance of the duties as outlined by Anna. A couple pieces, report back to 2 committees or 1? Do we want to hear back in HHS about this? Yes, I see some head nodding, so that's a yes. Do we want the primary report to go to us or to judiciary? So, yes, Representative Meyer?
I would say Judish gets the primary report.
Representative Stover, is that where your hand was going?
My question was, couldn't it be both? It could be the primary to the
Yeah.
judicial, and we get copies.
So I think we're already going to get a report here. The question was, are we primary or secondary? And it sounds like it really ought to go to judiciary and also to HHS. And then the last remaining piece I'm aware of is the emergency preamble. Is everybody comfortable attaching one of those to the bill? Okay, I see some head nods there. All right. So those are the issues that I surfaced. What others that we haven't touched on that we want to touch, we want to get to before we consider a tabling motion? Representative Reisman, how's this sound to you so far?
I think you're making great progress and I support your efforts.
Okay. So not hearing any other elements. Yes, Anna.
So Jeff just sent me the language, and I'd like to show it to you, if that's all right with you,
Sure.
of the
Sure.
involuntary commitment. Thank you, Jeff. Now I just have to figure out where I had it on my page. Yes, okay. So you can see, this does have an emergency, by the way. So it does say, I haven't seen this really before, but that in accordance with the offer extended by the Chief Justice of the Supreme Judicial Court in her letter to the Joint Standing Committee on Judiciary, shall convene a working group. So I guess that means if you get agreement from the judicial branch, you could do something like this. I've never seen language like this before, but I see why, because you can't tell the judiciary branch to do the judicial branch to do something, but you can invite them, and so I guess they offered. So I think if you were able to get the judicial branch to agree to that, then you could do something like this. And I guess you don't have to be too specific about the numbers anymore, because the 13 applied to a legislative study.
Right.
So you could determine who you wanted to be included. You wouldn't have to be too specific about the numbers of district attorneys or whatever. You could just say, we want these people on your stakeholder group.
And you could add the including but not limited to phrase.
Right. Yep.
To give them
Yeah,
ultimate
and
flexibility.
that's the other interested parties down here. So, and you can always invite legislators. That's not something you would put in the bill, but that is something that you can do. So thank you, Jeff, for that. That does answer my questions about how to draft that, but it certainly is predicated on getting that sign off from the judicial branch.
So it sounds like it would be a good idea to have a conversation with the judicial branch before we go too much further down the road. And Representative Meyer? You're on mute if you're speaking.
Thank you, Mr. Chair. Sorry about that. I would move to table 629, LD 629. Awaiting awaiting a conversation with the judicial branch with Julie Finn.
I'll second the motion.
So it's been moved and seconded. I think we can do this with a show of hands, and all those in favor of the tabling motion. So that's unanimous of those present. Thank you. So this motion is now tabled. We'll bring it back. Maybe Anna can help us with the best way to get in touch with judiciary. Or are we just going to go through Ms. Flynn?
I'll write an email or a letter, and I'll make sure that the chairs sign off on it before I send it.
Okay.
And then I'll let you know when I get a response.
And are they willing to convene? Are they willing to do some staffing? Are they willing to take on the process and report back to 2 committees? Those are the questions I'm aware of. Okay. So tabled it is. All right. Thank you all. I think that was a productive conversation. And Representative Reisman, sounds like it's definitely worth pursuing, and we'll give it our best.
Thank you very much.
Good to see you. Next, we'll go to consideration of LD 1385.
Okay, I have to keep moving you all around my screen in order to see what I'm trying to look at. Okay, LD 1385. This is an act to provide for timely placement with respect to violent patients in hospital emergency rooms. This bill requires emergency departments of healthcare facilities to discharge a person exhibiting violent behavior once the person has been medically stabilized, and directs the Department of Health and Human Services to establish measures to ensure the safety of emergency department staff and provide appropriate treatment to persons admitted to emergency departments who exhibit violent behavior. Measures include protocols for security placement and timely discharge, requiring the unit within the department to accept the person once the person is cleared for discharge, secure alternative care site within 24 hours of a hospital's request for replacement. There are so many typos in that particular little piece, it's not funny. Requiring a residential care facility to take a person back, creating an enhanced rate when a bed must be closed due to staffing or safety concerns, and covering the cost of security in the ER, and increasing the number of secure residential treatment adoptions. There's another typo. So issues from the testimony. You heard from the sponsor and proponents that violent patients are stuck in ERs that are awaiting appropriate placement for treatment, or the facility the patient came from discharges them and won't take the person back. That's not safe for staff, other people in the ER, or law enforcement where the hospital doesn't have their own law enforcement. You heard from Northern Light that their intent is to focus on delays in discharge once the patient is stabilized and clinically and behaviorally appropriate for discharge back to the originating facility. They requested a number of amendments, including adding language to say that healthcare facilities are not required to immediately discharge the patient if there is no appropriate placement for the patient. They cannot be safely discharged, or if the discharge would violate state or federal statutory or regulatory obligations. They also asked for removing residential from the section that requires the patient to be taken back, and another amendment request is to require the department to approve any denial of readmission back to the facility. And they also asked for removing the paragraph F, that's this one up here, about covering the costs of security in the ER. Maine Health, they also echoed those amendments, and also wanted to add to the duties in the introductory paragraph of subsection 2. It would say a person who is seeking treatment for a mental health diagnosis and exhibits violent behavior. And they were also asking for the department approving any facility denial of readmission back to the facility. The department is opposed. ERs must assess for blue paper criteria, another typo, when an individual is in a mental health crisis. They also cited the federal EMTALA requirements. Medicaid does not pay for added security because it's not a medical service. The department already works with ERs to assist with appropriate discharge and transfers. They have a PNMI gatekeeper in the department that has authority to authorize the enhanced rates to Appendix E. That gets at paragraph E, not Appendix E, but a paragraph E about the enhanced rate. Psychiatric facilities work with the ERs on referrals for involuntary hospitalization. Main Care and Behavioral Health have rule and contract language that requires mental health providers to have permission to deny referrals of persons with serious persistent mental illness and to terminate those individuals from service. And they also pointed out that no one department office is responsible for all violent patients. There are no current rules or statutes allowing for secure residential placements as differentiated from secure inpatient hospitalization. Disability Rights Maine is also opposed because of EMTALA, and they said that the bill doesn't include a definition of medically stabilized, and that could result in a person being discharged from an ER under state law that is violating that federal law. And you also heard some opposition to the language requiring residential facilities to take a patient back once medically cleared. Sweetser said that there are times when a patient has to be transferred to an ER by police and typically are recommending a psychiatric hospitalization for intensive treatment, and they do usually take them back, but post-hospital. And the Alliance also said that when a facility cannot manage a patient, they can't take them back into care, but they did support some parts of the bill, including the enhanced rates and increasing the number of secure residential treatment options. So I don't usually like to summarize quite so much testimony, but the reason that I did that is because there were so many requests for amendments in there. And so instead of putting them in drafting issues, I have put those in the testimony, the things from Northern Light and Maine Health, and also Disability Rights Maine. And I did just include a little blippy about EMTALA for you, about since that came up a number of times, and you can see there that it imposes obligations on hospitals, and it is something like 98% of hospitals that offer emergency services, that they have to require a medical screening examination when a request is made for examination or treatment for an emergency medical condition, regardless of the individual's ability to pay. And then hospitals are then required to provide stabilizing treatment for patients with those emergency medical conditions. And if a hospital is unable to stabilize a patient within its capability, or if the patient requests, an appropriate transfer should be implemented. So if, like me, you didn't know a whole heck of a lot about EMTALA, that's just the short version of that. And we haven't yet received anything from OFPR, and hopefully there are folks in the waiting room if you have more specific questions about how this currently works.
So that analysis allowed Anna to check off the use of the term blippy that she has to do at least once a week. Are there any questions from the committee about that analysis of 1385? Any comments, response to that? Representative Perry. You're still muted, Representative.
You'd probably prefer that.
Record will reflect that that's not true.
Well, you have to joke sometime.
I know.
I think that, and I'm looking at this, I mean, the problem, what we're trying to do is correct the symptom. And the problem really is access, not to the hospital, but to the placement. And I'm not sure this is going to do anything to change that. So I guess my question is, does this really provide anything we can act on?
Okay. Any thoughts about that? The argument being that the issue for getting people to the right facility has more to do with availability and access than it does with some of the other issues that this bill tries to address. Representative Zager?
Thank you, Mr. Chair. I just noticed that Representative Dodge is amongst us, bill sponsor. Perhaps we could bring her into the conversation.
I was looking for her and I didn't see her, but welcome, Representative Dodge. Did you have a chance to hear that analysis?
Thank you, Senator Claxton. Good morning. Thank you to the members of the committee. I was only admitted as part of the analysis, and I would love to have a copy of that if I might be sent that. It would be wonderful.
That's something you can orchestrate, Anna?
I'm on it.
Thank you so much. In terms of what the bill hoped to do, Representative Perry is exactly correct. This was just to, again, and I know you guys are bombarded daily with, please, can you help us on so many facets of our healthcare system? But this remains a problem, and I hope that you folks have been able to address some funding and creation issues around expanding our treatment facilities.
That's not specifically what's addressed in the bill, but has been a focus of the committee for
Years.
quite a while. Yeah, so we share that intent with you. And we'll hear even more about that in the next couple of bills we're going to consider in terms of mental health and community-based services. Okay. Any other thoughts that people want to offer? The concern is bumping up against EMTALA as somebody who's lived in emergency rooms as a provider. It's a big hairy monster. EMTALA is, and then trying to mesh this with that will be a real challenge. Senator Moore.
I was going to say that myself, Senator Claxton. I think that that's an issue. The other thing I'm thinking about too is that right now the emergency rooms are, they are able to do the blue paper criteria if need be. So that kind of gives you that emergency situation action, for the when someone's in mental health crisis. So, in my opinion, I'm going to make the motion ought not to pass on LD 1385.
Motion's been made.
I'll second it.
And there's a second. Representative Meyer, did you have something you want to contribute?
Thank you, Mr. Chair. No, Senator Moore contributed before me.
Okay. All right. Any further discussion about this issue based on our concerns about bumping up against EMTALA and in the perspective of multiple other efforts ongoing to try and do what we can in our committee to help with community-based services? Not see, oh, I see Representative Stover's physical hand.
Yes, I put my physical hand up. Thank you, Senator. I just want to acknowledge the bill's sponsor for the intent of this bill, which is to really push towards increasing access and availability of treatment services. So thank you.
Thank you.
Representative Meyer, is your hand up again? No. Okay, just looks like it. Okay. All right. So I guess at this point, the motion on the floor is ought not to pass on LD 1385. Ms. Withy, if you would collect the vote.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 10 yes, 3 absent.
So Representative Dodge, thank you for your efforts to highlight a significant issue and make that higher profile.
Thank you for your work. Good luck.
Thank you. Thank you. I didn't say in the introductory remarks earlier, but I should have, that we have a certain allotment of technical difficulties we have to encounter every day. We haven't run into any of those yet, but I just wanted to flag that. And the other thing I wanted to flag was that there's a number of committee members who aren't here for various and very good reasons. Some in committee and some distracted by other issues. So I just wanted the public to know that these are not people being inattentive to their responsibilities, but they have lots of other parts of their lives that they're filling in or committee meetings that they're attending. So thank you for that. So along the lines of the conversation we just had about expanding services or recognizing the need for services, I think we'll move on to consideration of LD 968 and 1586 together, since there's significant overlap.
Okay, so LD 968 is a resolve to expand mental health crisis intervention mobile response service. And this resolve requires the department to expand mental health crisis intervention mobile response services to provide 24/7 to the entire state. And the department is directed to do this using funding provided for an RFP for a behavioral health crisis center services. 1586 is an act to strengthen statewide mental health peer support, crisis intervention mobile response, and crisis stabilization unit services, and to allow E911 to dispatch using the crisis system. So this is a long bill, so I have taken a little bit of time to break down each piece. I'm sure we'll find plenty of typos along the way. So Part A of the bill requires increased resources to the statewide crisis lines and warm lines. It also requires the department to work with the Department of Labor to access grant funding to provide training and workforce development for peer support. And that section includes an appropriation in each year of $45,469. Part B requires the, I knew I was going to trip over that, certified intentional peer support services, SIPs, and recovery coaches, mental health law enforcement officers co-located in law enforcement agencies, and mental health professionals at E911 dispatch centers. It also requires support for ancillary services, including travel costs and travel time. And when the contract is renewed in October, it must include a cost settlement reimbursement mechanism and peer support services. Part B also includes appropriations for mobile outreach peer support specialists, certified intentional peer support specialists and recovery coaches, mental health law enforcement officers liaisons co-located in law enforcement agencies and in E911 dispatch centers, community debriefing and critical incident response services and ancillary services. And that includes an appropriation in each year of $2,990,081. Then Part C requires the certified intentional peer support specialists and recovery coaches as part of mental health crisis stabilization unit services and other resources needed in public health districts. And it requires the department to reimburse for peer support services as part of health crisis stabilization units under the main care program beginning October 1st, 2021. And that part includes an appropriation of $1,265,753 in each year. And apparently I don't know what a period is there. Part D requires a public education campaign to educate the public and work with law enforcement agencies to ensure knowledge of availability of services, and that includes an appropriation of $100,000 in each year. And I do just want to remind you that the sponsor requested amending that bill to remove E911 from the bill, which I think comes out of several pieces of the bill. It's not just one section that you can strike. So there are a number of issues from the testimony. You heard that the crisis system, and this is for both bills, the crisis system in Maine is built to respond to behavioral health crises, but is underfunded. There is a map of 8 districts, 7 agencies, and a number of mobile crisis workers that was sent separately. And I resent that to you this morning, I think, because I forgot to attach it again. Law enforcement often have to respond, and those folks can end up in hospital or jails, and the system of mobile crisis needs to work all the time to be a reliable alternative to law enforcement. The bill includes peers in all part of the crisis system. It was included in the last RFP but dropped in the implementation, and there was also some testimony that they were happy to hear that the department is again working on the peer support main care code issue, which has been raised a couple of times in the last couple of years. You heard about the FEMA funding that is supplementing the warm line that will end in May 2022. You heard from the Alliance that there's a need to amend Section 2 that the fee-for-service model doesn't work for crisis, and there's a need to revert back to the cost-settled model for all crisis services, not just crisis mobile response services. And they also requested removing Part D, the public education part. There were certainly some opponents to 968 for diverting the funding from the crisis centre. And then you heard from the department about the statistics of the number of calls to the main crisis line that end up in mobile crisis, the response time, and the response time for the phone calls as well as the response time for the mobile crisis. And you heard statistics about the involuntary and voluntary hospitalization. The missing component is the crisis center, also known as receiving centers, and they questioned why the proposal in 968 would defund that RFP for a crisis center to fund mobile crisis. And Dr. Pollard, who I do know is in the waiting room as well, said that Maine will have all three of the components of the SAMHSA best practice with a crisis center, somebody to talk to, somebody to respond, and somewhere to go. The American Rescue Plan includes enhanced FMAP of 85% for mobile crisis, and they anticipate the rollout of the 988 number next year, and the rate review is examining how crisis services are reimbursed. She also mentioned that the CSU language, the terminology for 24/7 is up to 24 hours with peer support, and residential services are up to 7 days. So I just wanted to remind you that there was this request for removing E911 from LD 1586. And I just don't know enough to know whether the crisis stabilization unit language in Part C of the bill is being used correctly. I know that Dr. Pollard talked about the differences between crisis stabilization units and residential services. I'm just not entirely clear whether that there are some drafting issues that need to be corrected or not. So I just want to raise that as a flag because I just don't know enough to know. Cumberland County Crisis Center budget proposal. That initiative is described as provides funding to continue the crisis center in order to meet the requirements of the consent decree to provide crisis services in Cumberland County. That item has an annual general fund appropriation of $250,000. It has not yet been voted by AFA. It wasn't included in the skinny budget in LD 715, so that is still out there. You had requests for crisis funding over time and information about the peer support being dropped from the implementation of the RFP, and I did pass those questions on to the department. And also you asked, Representative Zager asked for information about better outcomes from other states, and I know Betsy Sweet has been working on it, and so I don't know whether she has communicated directly with Representative Zager, but I do know that she's here. And then the OFPR preliminary fiscal impact statement for LD 968 has a potential cost biennium cost increase to general fund. The bill requires the department to utilize funds currently allocated to an RFP, and the department notes that this service is already being provided statewide 24/7, and the bill doesn't include new funding. And so if there are some changes identified, there may be new unfunded costs that could impact some of the other programs. They would have to shift money around. We haven't yet received the preliminary fiscal impact statement for LD 1586, but those appropriations that are in the bill have a total of $4,401,303 in general fund money in each year. So once again, I'm sorry about all of the testimony summarizing, but it's the way to get at the drafting issues.
All right. Response from the committee. Any thoughts, questions, concerns with that analysis? Okay. I see we've been joined by Representative Supaga. Would you like to chip in response to Anna's analysis? Welcome.
Oh, thank you. Good morning. Yeah, I guess I would just kind of respond with, you know, we say we have 24/7 crisis response, but, you know, go ahead and try to reach out for a family member that you need somebody to respond to, you know, whether it's, you know, in the middle of the day or, you know, 8 p.m. on a Saturday night, and you're not going to get a hold of anybody. You're going to end up, that crisis is going to end up falling on the Bangor PD's shoulders, at least in my town. So, you know, I just wanted to reiterate, like, what we, you know, there's it's really easy to look at these things in a chart, but the reality of what's happening on the ground is we're in desperate need all over the state. So I don't know if there's a specific question you wanted to ask me, but that's just kind of where my thoughts are on the matter right now.
Okay, thank you. Any questions or at this point from the committee? We have had some data presented to us, Representative, that would imply that crisis is pretty good at responding. We may not be getting the right resources to the right place at the right time. I understand that distinction. And we've been joined by Dr. Pollard. Welcome.
Good morning.
So did you have a response to what Anna had to say or what Representative Supaka had to say?
Yeah, I'm happy to share further information with the committee if that would be useful. I think a really important distinction does need to be made between what crisis stabilization units are and what we have as existing services in the state. So I don't know if there's time or interest in walking through a few visuals for that.
If we can just do a couple of definition pieces about tiered care, where I think there's general support in the committee for community-based mental health services. The question is structure and dollars, and I guess the department's vision for where you're trying to get to versus where we are right now.
Sure. I also have information on spending, if that would be helpful. Should I just kind of quickly go through a few bullet points, and then if that doesn't provide the clarification, I'm happy to answer more questions.
That'd be helpful to the committee. Yes, Representative Zager.
Well, I just thank you, Mr. Chair. I just wanted to call attention that Betsy Sweet has shown up in the attendees. So at the appropriate time, maybe we can bring her in too.
Thank you. Sure. Why don't we see what we have from your information there, Dr. Pollard?
Sounds good. Of course, as soon as I say that, I have lost track of my slides. Ah, there they are. Okay, so just quickly, since there have been some questions on spending over time, and I wanted to make sure we had the right information and context, although that just completely put me at the wrong slide. Apologies. I am taking care of your technical difficulty portions for this work session.
Thank you. We can check that box off now.
Happy to be of service. So this gives you a compiled view of the department's spending on the crisis services over the last 4 years, so inclusive of main care and department contracts, which cover people who do not have main care for a variety of services. And you can see that in the last state fiscal year, we added some significant increase in resources to the array. I excluded residential as that is a significant component of the expenditures. So removing the main care crisis residential from the equation, you can get a different sense of the level of spending. And I realized I clicked off that last slide very quickly. Let me just go back and point out that this is a figure of, I think I actually may have we've got a legend down here, but we're talking about upwards of $150 million in expenditures when we look at these figures combined. So I just want to give the committee and others a sense of what the level of expenditures really looks like for crisis services across the state, so we have that context. Looking at just the contracts and the main care reimbursement for mobile crisis, unfortunately, it's very hard to pull out the breakdown of expenditures from the contracts so that we have main care claims for mobile, and then we have contract payments or contract allocations to providers. So you can see that it's a relatively level spending over the last 4 years with an increase in the last state fiscal year as we've added some additional services and investments. And I think it's also helpful to look at the volume of people served, because I think, I agree that it's not just about the level of financial investment from the department, it's also how many people and in what kind of time frame are we serving people? And to look at the data, I do think is important because I am mindful that people are not always aware of the existing services in order to access them. I was actually kind of disappointed to see the recommendation to remove a public campaign component from the bill, since I think that's actually really useful to make sure everybody is aware of what's out there, particularly as we start to make the 3-digit number and a resource that will make, I think, a big difference in diverting callers from 911 and the emergency department. But getting back to the point here, which is how many people are we actually serving outside of those dollars? And you can see that there is a significant increase in the number of people that we've served in the past state fiscal year. And then this is just in case anyone was going to ask me a detailed question about what was on those slides, I put it in a table format. So it's there in case you were having trouble unpacking the bar graph with your eyes. Then there's also the question of workforce. So this graph, it's important to orient you to the fact that it's cumulative, meaning these are new issuances of mental health rehabilitation technician crisis service provider certification. So 2007, 2008, you see those high numbers because that's when that new credential came online. And then each year represents the number of new CSP certificates issued. So think of this as a cumulative number, now totaling 1,175 CSPs issued. And as mentioned in the analysis, we do think it's important to follow national best practices. These are not simply fad recommendations. This is based on 15 years worth of work by by SAMHSA and by other provider organizations or national crisis provider organizations, including the National Association of State Mental Health Program Directors, the consortium of different organizations that built the Crisis Now, the Interdepartmental Serious Mental Illness Task Force at the federal level. So these are pretty well established consensus guidelines for what are the core components of a robust crisis system. And we are doing pretty well in terms of having 2 out of 3 of those components up and running, although I will note that the mobile crisis teams should ideally be dispatched to the community, not to emergency departments to meet with people. And I'll point out why I call attention to that in just a moment. And then as well, I just need to correct a really common misunderstanding. People use the term in Maine crisis stabilization unit, though that's not how it is defined in Maine Care rule. What they're really describing is crisis residential services. So people use the term CSU, well, I don't want to say incorrectly because it's our local vernacular, but it's different than what is meant in the SAMHSA best practice guidelines when referring to CSU or crisis stabilization. So by the national definition, it's 24/7 walk-in, take all comers facilities that serve people with rapid assessment and triage on site, typically includes peer support, and is less than a 24-hour stay. So some people are assessed and triaged back to home or back to some follow-up service. Some people stay in what we think of as chairs, so they're not beds because they're less than 24 hours. But the person can stay there and get support, often in the form of peer support in a comfortable, welcoming environment for up to, but not exceeding 24 hours. This seems to avoid the need for such high rates of admission, not only to inpatient units, but also and emergency departments, but also to crisis residential. As you saw in the earlier graphs, we have a very high rate of expenditure for residential service, crisis residential. And then this is just in writing what I essentially said already about what we have in Maine. We have the 8 regional teams. I think that's been shared with you already. I do want to also note that the Wabanaki Health and Wellness provider agency also has a tribal crisis team with a tribal care line, Wabanaki care line, and that we are in the process of implementing our first comprehensive receiving center, which we've referred to as the Cumberland County Crisis Center. And then we do, as I said, have the residential component. But the residential component, just to do a side-by-side comparison, that doesn't include the components that are really key for crisis stabilization. So while we have residential, those don't take people just walking in. Their doors aren't open to rapid assessment and triage at those facilities. That's done by the mobile crisis team, who can then refer people, if appropriate, to a residential level of care to the crisis residential facility. And with a rare exception, peers are not currently part of that staffing model. In contrast, what we're aiming toward as an additional component to round out our service array really needs to be 24/7 walk-in availability. It really needs to take all comers. So not kind of turfing, but saying, walk in the door will at least help triage you to the appropriate service if we don't provide it ourselves. And up to 23-hour observation, which we really feel strongly committed to having and take place in a peer living room model. And also bridging outpatient services, because as we are aware, we need to continue to build access. So this model provides that short-term support until the person can get to the next appointment with ongoing care. You already have these data. Yes.
Dr. Pollard, can you go back to that prior slide?
Absolutely.
On the 1, 2, 3, fourth bullet under crisis center stabilization, it says more than 24 hours observation. I understood. Is this the living room model that's less than 24 that you're talking about here?
Yes, I must have used the wrong symbol. That should say less than 24-hour observation.
Okay, thank you.
You know, I'm trying to go back to my kindergarten days. The alligator mouth is open to the larger thing, and I oriented it in the wrong direction.
And the same way with the alligator on the right on the fourth bullet.
Yeah, the alligators are failing me, I'm afraid. That should be less than 24 hours. That's what I get for trying to use shorthand quickly when putting slides together quickly. Thank you for pointing out my error. Yes,
no, I was trying to help my understanding.
And here I was trying to clear up confusion, and I potentially added more because these are the slides I sent you. But yes, while the center is open 24/7, people can only stay there for observation and support or stabilization for up to 24 hours.
And that's the piece that you're saying is missing now and is being RFP'd for Cumberland County.
It's already RFP. The RFP is completed. And I would say the other piece that's missing is the 24/7 walk-in, the place to go component of what SAMHSA best practice guidelines state. You know, I think it's important to acknowledge this. I mean, there's a lot of system improvement planned that will be helpful. And at the end of the day, we live in a state where there are huge geographic distances, and having the most robust set of mobile crisis teams is still going to mean there are people who live an appreciable difference from where the mobile crisis facilities or where the mobile crisis team is, even if we greatly expand the number of people who are out in the field. You know, I can relate to some extent, having grown up in rural Bradford, Maine, where even if you needed law enforcement response, that could take upwards of half an hour or longer to get a response from 911. So I do think, besides it being best practice, I think in a state like ours, we want to give people that alternative of a place to go for yourself, for a loved one, if law enforcement are involved, giving them that alternative place to go from the emergency department or jail. And that doesn't exist now with either our crisis stabilization unit. I'm sorry, I just did it myself. That doesn't exist with the crisis residential. And our mobile crisis teams are 24/7, but the walk-in component of their kind of where they deploy from is only business hours. It's not 24/7, and it doesn't include short-term observation.
Okay.
You already have these data. So the
Yep.
point here is simply that based on the metrics that we have from the main crisis line, the calls are answered quickly. This is not a small number of people who are making use of the line. We're talking of, upwards of at minimum 6,000 people a month, but on average closer to, around 9,000 people. Of those, a small percent, fewer than 2,000, are referred to the district mobile teams. And then you see an even smaller percent are referred to emergency response. And I'll pause because I think there's a question, and maybe it's about the particular slide.
Representative Perry?
Yes, thank you. Actually, my question is, looking at the crisis center that is the pilot, I think is what you're doing at this point. Is there intent, if this is used well and working well, to actually go to other populated areas like Lewiston, Bangor, Augusta?
Yeah, thanks for the question. We're not actually considering it a pilot. We've been thinking of it as a demonstration project. To me, a pilot is an establishment of the effectiveness of the intervention, and that's already pretty well established, I would say, from other states and the existing literature. We wanted to really learn from the process of implementation, how this could work in Maine, because there are differences, for example, between state Medicaid rules that would need to be addressed. Really, how is it going to work on the ground in our particular state? So yes, it is not our intention to stop at the Cumberland County one. And I have a bullet point or two about future state that I can get to pretty quickly. I think you have these data as well. It's just to call out that unfortunately our current state, the current situation is that about 47% of our mobile crisis assessments take place in the emergency department. And that is not what we want. That's not best practice with mobile crisis response. To put it in context, part of the reason for that, however, is because, and I should have given you these data as well, the calls to the crisis line, a significant portion of them originate from the emergency departments. So some of the emergency departments don't have their own consult liaison or mental health crisis staff. So they call ours, and our staff, our crisis, contracted crisis providers go out to them.
So moving along.
Yeah, you don't really want to go into these detailed data on time to contact. All right, well, it's quick, relatively speaking. But I do want to acknowledge that often that these data don't necessarily reflect who doesn't call the line, of course, who goes straight to 911, which is going to get them a law enforcement response, who goes straight to the emergency room. Of course, none of that's captured in these data. And it also doesn't reflect if somebody calls and says, I don't want to wait, I'm just going to take myself to the emergency department. So you were presented with the mental health working group recommendations. You've heard a lot about them this session. I just want to point out that really the last two bullet points in the working group recommendation on crisis services really describe crisis stabilization units as they are as they're defined, really kind of in the shared national language, not as crisis residential. So if you see here, it says 24/7 with peer support where acceptance cannot be refused. That doesn't represent, as described in the LD, it's described as an expansion of existing services, or existing contracts and services. That isn't actually something that exists in our current contract. So I just want to keep making that point because it creates some confusion, even I think in the way the legislation is written.
And do I understand that the crisis stabilization, again, 1, 2, 3, 4, fifth bullet point, crisis stabilization units, that could also read with peer respite in that first line, because that's inherent in the definition of the CSU used in the national language.
Yeah, I mean, it is not a requirement of the CSU, but it is common practice for CSUs to include peer support.
Okay. And there's some evidence-based experience with that.
Yes.
Yes, thank you. Okay.
All right. So we don't have them, but we're working on it. We have one in process and plans for more. So I'm getting to the good stuff, to the question about what are we planning to do? Is it just one? So a lot of these bullets, you'll notice, are really corresponding to what's consistent with the consensus recommendations. We already have expanded the peer warm line during the context of the pandemic, and then we have extended that into the next state fiscal year. I want to correct something that was in testimony that is not accurate, which is that this is entirely FEMA funded, because we have allocated a new federal grant dollars to continuing the expanded capacity of the warm line. And I don't think it's accurate to say that we necessarily intend to decrease or end that expansion. We have it moving into the next state fiscal year with new funding available to us. We created, in partnership with NAMI, the teen text line as another kind of peer support option. We've expanded our peers in the ED from 2 hospitals to 7. That's in process of scaling up, and we are now up to our goal of 9 EDs with recovery coaches. We have training in process. We completed some crisis counseling or emotional first aid training with the 211 call center staff, and are adding some additional training in the context of our service locator tool that we're launching. So 211 staff will recognize signs of mental illness and substance use disorder and have better skill sets for making targeted referrals, making use of the service locator tool once it comes online. We did just make an expansion to the staffing for the main crisis line to increase their capacity using a new block grant set aside available to Office of Behavioral Health. You've heard a lot, I think, about options. There's a budget initiative for the Justice and Health team, which is law enforcement co-response focused, or pre-booking diversion. About the crisis center pilot. I want to make just one note about the budget initiative. That sounds like a very small amount. And the reason for that is because we had delays in implementation due to the pandemic. And so we have existing funds set aside for the implementation period, as well as some of the initial operations. And we want to get a better sense of the true cost once it's been implemented, so we know what we're looking at for the gap between reimbursement and cost of service. So the budget initiative is really a small amount at this point. So we are expanding an existing aftercare pilot of OCFS that started with Aristic Mental Health Center to statewide. So we are just about to announce that a little bit more widely, but I wanted to share that with this committee. So that is for in-home supports for children and families when children present to the emergency room and have placement challenges. You saw in the first draft of the biennial budget that we have plans to launch the mental health intensive outpatient program, which is a really important missing layer in service array that will allow us to avoid escalation of crises or work with people who are kind of heating up to avoid inpatient stays and help get people out of the hospital. Happy to talk more about the planning work we're doing with the 988 coalition to make sure that our system is ready for scaling up in collaboration with Department of Public Safety, a number of stakeholders, including crisis service providers, to figure out like really what is the capacity need, what is a reasonable timely response to a 3-digit crisis number. And then we are, to Representative Perry's question, at using federal funds available to us to scale up the existing crisis contracts to include 24/7 walk-in care support and a stabilization component. So that is hot off the press as well, and something we need to discuss with the crisis providers in more detail, but we are committed to using new federal relief funds to that effort. And then you may already be aware that we have availability of planning grants from CMS for mobile crisis and strong consideration of different reimbursement mechanisms as part of that planning process. So I know I've given you quite a lot of information, and I really look forward to speaking with the committee after the governor releases her budget so we can have a discussion about how new initiatives will impact issues around service access, and pretty excited for the plans that we'll be able to share.
Thank you for that. We've been in touch with Molly, who will be setting up an opportunity to hear some more about the budget in the future. Does that raise any questions or concerns for folks? Need for additional information? Yes, Senator Moore.
Thank you, Dr. Pollard, for that very thorough presentation there. I guess my question, and through all of this, it sounds like there's a lot of work being done in the department. Is this bill really necessary? Do you need additional funding, or do you need something from us to help complement the work that you are already doing?
Well, I mean, I think that there were some interesting ideas in the bill around making sure that we train 911 dispatchers. I don't know that necessarily requires legislation. We have DPS and the Emergency Services Bureau participating in planning and quite eager to develop those protocols to go from 911 to 988 and vice versa. I think a public campaign is a great idea. We do need greater awareness of the resources. But I would say that I don't think there are any statutory barriers to anything that we're envisioning, and we are committed to investing significant resources that are available to us in some system improvements. So I appreciate the intent, and I'm not entirely sure that the legislation is necessary.
So I do notice we've been joined by one of the sponsors, and I want to give her a chance to respond to whatever portion of this you've heard without inviting us to try and replicate it. Representative Warren.
Thank you, Mr. Chair, for the opportunity. I have been here listening, and I thank you for that. Thank you, Director Pollard, for that information. I would just say that the proof of whether we need these services or not is in our overflowing jails and prison system with folks who are struggling with serious mental health issues. If you have questions about whether what we're doing is working, I think the sheriffs and the beat police officers out on the street can answer the question. And they've been asking me for 7 years for more help, and that's what I'm attempting to do here. We are serving people with mental health issues, but we're serving them in our county jails and in our prisons. It's very expensive and it doesn't work. And that is what this bill for me is about, is at the point of interaction. Instead of a police officer making the determination of what happens with somebody that's in crisis, somebody that's trained to do that work instead is at the scene. So thank you for the opportunity to weigh in. That's all I have for you right now.
Thank you. Representative Zager.
Thank you very much, Mr. Chair. I actually have had a question for Dr. Pollard based on your excellent thorough testimony, and then also just something to offer for the committee's consideration generally. Dr. Pollard, can you please paint a picture in our minds of what the living room physical space looks like? The graphs are really helpful in one sense, but can you just help us understand what the venue is for this service being provided?
Yeah, absolutely. I think that I have to be better about recognizing not everyone gets as excited about graphs as I do. The living room model is deliberately named to reflect it's meant to be a home like environment. It's meant to be welcoming, comfortable, and staffed by peers. So, if you think about what somebody's experience is like in crisis, if they're going into an emergency department, there's bright fluorescent lights. You might be sitting on a gurney. I unfortunately had the experience of taking my toddler to the emergency room not long ago and was there 5 hours. It was not a place where I would have felt soothed and comforted if I was experiencing a mental health crisis. So the living room model, now I'm kicking myself for not bringing pictures of what some of these look like in other states, really should look more like somebody's home. I mean, that's where the term comes from: comfortable place to sit, nice lighting, a place where you wouldn't mind hanging out for several hours as you get support and try to work on accessing what you need, whether it's skills or resources, in order to stabilize the crisis and resolve the situation. So picture your living room at home, and maybe a little bigger. I don't know what size living room you have, but it would have to be large.
With some space off of it for private conversations.
Correct. Yeah.
Does that answer your question, Representative Zager?
Yes, Mr. Chair, it does. Thank you, Dr. Pollard. The other thought I had after what Representative Warren, Bill's sponsor on 1586, discussed, I personally am in agreement that our system is not really aligned well, and more funding is needed. And so I would just offer for the committee's consideration something to boost that, something that would help boost the number of crisis workers that are part of a system that might not be funded well or aligned, and therefore not focused to address the needs in the time and the place where they are best suited.
If I could just add to that, I don't know if I was clear in my response as well. You've seen the previous version of the budget, and you'll see the budget that's about to be released. We are not in disagreement that some additional funding resources would be helpful to address some of these systems issues, and that's why we have specific budget initiatives that the department has requested in order to help facilitate some of these changes.
And the big variable there is the size of that and future federal dollars, both being to a certain extent, well, they're definitely unknown to us, but yet, at least in the one case, we'll be finding out this week about the budget. But the federal dollars still aren't defined and would have some significant mental health component to them. That's the big variable right now. We wanted to hear too from Betsy Sweet. Welcome.
Thank you very much, Senator and committee. Thank you for just a few minutes. And thank you, Dr. Pollard. That was excellent. And I just want to say that the original intention, one of the original intentions about trying to move the money in Representative Supika's bill was really based on only on funding shortage, right? So if there's not enough money to go around. So as we see more money in both the state budget from additional revenues and the federal money, I know that for the Behavioral Health Collaborative, we support the living room model and other innovative models, and just want to make sure that they are adequately staffed and funded as well, and not just ultimately, as I know is Dr. Pollard's plan as well, out in the community, other communities as well. I think that the pieces, and if you look at Dr. Pollard's slides carefully as we did, one of the pieces is the underfunding of, or the pretty level funding of mobile crisis. We have had some really good support for increasing the warm line and the crisis line. And we have had an exponential increase in the number of people trying to access those services during the pandemic. And growing, as Senator Warren, Representative Warren has said, over the last 7 years. So we can keep seeing this intense need. And you hear from the hospitals, the 2 bills you just were working on were about people with behavioral health needs coming to the hospitals. So I think that there is, even though there are some great plans, and unfortunately, because of the timing and stuff, we have not been privy to those plans and what the new initiatives are in the budget. And we very much look forward to seeing those. I think we really have to look at what's happening on the ground. And Representative Supika said what we hear all the time, which is people call mobile crisis, and if somebody's out on a call, there's nobody left, and it could take 2, 3, 4, 5 hours to get somewhere, and then that person ends up in the emergency room or interacting with law enforcement. So really, that was the big recognition of the working group, and it is what people on the ground are telling us, both people who are working the crisis system, right? And I remember I was speaking at somebody's social work class, and there was a crisis worker there, and he was in tears. He said, we get called for a crisis and we're on a call already, and we say, well, sorry, we can't be there for another 5 hours. And they know that that person is then going to go to the emergency room of the hospital. Now, I know we can't take care of, as Dr. Pollard said, we can't take care of everybody. We can't make sure that the farthest reaches of the state have, 10-minute access. But I think we have to look at how we're spending those resources. And that really is the purpose of both of these bills, to make sure. Now, is this going to get taken care of in the budget? Wow, that'd be awesome. But that is not where we started out. And I think the other thing is to make sure that we have adequate peer support in all of these services, because we know that best practices show that that's some of the least expensive and the most effective ways of helping people when they are in a crisis situation. So that's where we are. And I think that, again, if you really look at those slides, the big jump in crisis is in residential crisis, right? I think there's also a conversation to be had about transforming our CSUs, both as step down from the hospital per your other bills that we have, as well as what they currently serve. So I think the idea of having somewhere to go is something that we are all trying to solve. I think that this living room model is awesome, and I hope we get it out there. I hope it's adequately funded. We're very concerned about having 24/7 psychiatry on board, which we want to do. I did send a email information to Anna and Representative Zager with some really additional interesting models that are happening around the country, including having cruisers have iPads in them that directly connect to crisis workers, so that someone can actually get some help in the back of a cruiser before they're taken somewhere. And so there's a lot of interesting, great models, and I don't think that this is not just of that, but I think that we have to keep open to those to solve the issues that both Representative Warren and Representative Supika are hearing from their constituents, and that we're experiencing. I represent 2 of the crisis providers, and again, we're very grateful for the expansion. We're grateful for the interest. And we need help. We need additional dollars, and that's what this bill is about for us.
Dr. Pollard, can you speak briefly to your vision of the ideal number of mobile crisis workers who's available, just broadly defined?
I don't have a set number right now. I think it's important to I think we have to look at the metrics a little bit differently than we have, because what we have right now is a little bit general. How quickly do people respond, but it's going to vary by where you are in the state in terms of population density. So that is work that we are engaged in around the 988 planning process, but I don't have it would be too much of a guesswork at this point, and not, I think, based on modeling that's going on right now with SAMHSA and NASHBID to try to help states figure out, based on your population size and density, what's the right size of your mobile teams and what's the right capacity for the call centers that staff the crisis line. So it's a little bit.
It's fair to say, though, that the plan is to expand those resources.
Correct.
Okay. All right. Senator Baldacci.
Thank you, Mr. Chairman. I think that everybody here really agrees that this is a problem, that this is an acute problem. I don't think anybody here is disagreeing about the nature of the problem or the extent of it. I think even the department, I appreciate their slides, but I think that they also concede that there's a significant and acute problem. But I think that we also have the fiscal side of this thing, and I think it would be appropriate for us to table these bills until we get a fuller understanding of the governor's bill. I mean, I understand we are running up against deadlines, but I think we got to figure out where the money, where her proposals are, where they're going, how they might impact this issue.
Representative
I-
Perry, are you seconding that? No.
Well,
Okay.
that's my motion, is to
All right.
table.
All right. Is there a second to that?
Okay.
All right. So it looks like the committee's not inclined to table right now. Representative Perry.
Yes, what I would like us to do is take 1586 and I think there is, and I've got to go back and look, one portion of 968 that would be worth putting into 1586 and combining those bills and getting an ought to pass as amended out of that. I have to go back.
You're on mute again. You're still muted, Representative. No, still muted. It's the other button.
Okay, right now, I'm looking at the bills to see which portion I want to move into 1538.
Okay. Representative Stover.
Regarding the tabling motion, I had it's something for the committee to consider. We have another bill. It was Senator Breen's planning bill. And if we weren't prepared to act on this today, possibly it could be brought over to be considered as part of that planning bill, is another suggestion I might make. But I'm more interested in Representative Perry's.
Representative Perry. Are you unmuted and have something to share? Jesus. Still muted.
I'm in the wrong place. No, I was just looking at 986 and I only see the concept. I have to go back and look at Anna's stuff. But the biggest thing is I think we should put in for the funding at least, even if it's covered by the budget, it still gives the message of the need that we have for mental health and mental health crisis. And I see this as a message regardless of where the budget is.
Thank
So
you.
I would second that motion then.
Is that in the form of a motion, Representative Perry?
Yes.
All right, so the motion has been made, ought to pass as amended. Now we have to be clear about what the amended portions are. Representative Stover and then Representative Meyer. Bye-bye. Okay, Representative Meyer.
Thank you, Mr. Chair. I would agree with Representative Perry. I think we need to use 1586 to demonstrate our support for strengthening the already existing crisis system, supporting the department's move towards the demonstration project and widening that once we know how that's working. I believe we do need to get specific on exactly what we're sending to AFA, but I would agree that we are a policy committee and we should send that message to AFA, and they will do the work around how this gets funded based on whatever is in being proposed in the governor's budget, as well as any federal dollars that may apply.
Okay. And the focus of 968 was on the mobile crisis response, and that's pretty clearly included in 1586. So there really is not, as I see it, a portion to bring over from 926 other than the admirable intent to expand those services, which aligns with what the department has said they'd like to do anyway. So that's fortunate. And then the other elements, are there any elements of 1586 that people think need additional attention? Yes, Representative Zager.
Thank you, Mr. Chair. A couple thoughts. One is the whole public education piece. I think that makes sense to keep in. The second point I'd like to make is that is a matter of calibration. I don't know the best practices for, say, per 100,000 people, how many crisis workers there ought to be in a well-functioning system. Somebody else out there may know, either on this Zoom or out there in the world. But when we're talking about funding and what are we going to be calling for in this ought to pass as amended proposal? One way to say is a certain amount of funding. Another way is to have an a benchmark in mind. And I think that benchmark ought to be evidence-based and on those best practices.
And okay, and I don't think there'll be too much pushback against that. Moving ahead, if we pass this bill now and send it on to AFA, and certain segments or all of it are met by federal dollars, or then we won't have lost anything, and we'll be clear what the committee's intent was. So any other comments? So the amendments, I don't see any amended versions at this point, but Anna's the one who's got to write this, so we'll go to her. Are you clear on the fact of where we're going with this?
No. First of all, I do want to come back to Representative Warren's original testimony, which was removing E911, and you've not talked about that at all. And then the other question that I had is, I'm sorry to be so dim, Dr. Pollard, but I still have no idea if Part C is drafted incorrectly or not. That's the part with the crisis stabilization units in it. So I understand what you're saying about the difference between the two, but I don't understand the language enough in Part C to know if it's right or wrong.
And I'm not certain I've seen the most recent version, if there have been changes, but it's problematic the way it's written as I last saw it to say the crisis stabilization units. If what's, I'm trying to think how to word that, we don't currently, the contracted services right now is one crisis center that's in process. And then we have 8 regional crisis contracts that are not labeled as crisis stabilization units. So I think the way it's worded in that section does make it problematic because that doesn't really exist right now.
But we could have Anna and the department work on getting that language to conform with national lingo.
Yeah, I understand that part. What I don't understand is the intent of the committee, whether the intent of the committee for Part C is crisis stabilization units as intended by SAMHSA and what Dr. Pollard is talking about, or whether it's residential. That's the first question.
Oh.
And then the second, which is the one that I think Dr. Pollard is also talking about, where it says the department shall work with organizations providing mental health crisis stabilization unit services, and there's only one, is that right? So that's problematic too. So it's just a matter of me, the dim one, understanding exactly what the committee is looking for in Part C, whether the intent is receiving centers, crisis stabilization units, or whether the intent is residential. And if the intent is the receiving centers, the CSUs, then I can work with Dr. Pollard and Molly to make the language
We'll go to
somehow.
We'll go to Representative Warren. So can you help us with the intent that you had?
Thank you, Mr. Chair, and thank you, Anna. I'm sorry that this is confusing for you. I refer to the small residential places we have in the state that help folks get their crisis stabilized as crisis stabilization units. Dr. Pollard, what do you refer to those as?
Can we include, before you answer that question, Representative Warren, can you include a time frame for stabilization? Are you talking about less than 24 hours or more than 24 hours?
In some cases, it might be 2 or 3 days, yes.
Okay, so now you're talking about what I think the language is to be residential and not living room, to make that
Thank you.
distinction.
Thank
Okay.
you. Yes, residential is the proper term. Then Anna, that's what I would like. Thank
Well,
you very much.
I was just making sure I understood the point you were making before I went back to Dr. Pollard. If we make that distinction, Dr. Pollard, does that conform with national language, independent of whether that's where we want to go now?
I have to say I'm now in the confusion boat with Anna because what we have now is crisis residential.
Right.
What's described and what I thought the intent was crisis stabilization. The way the crisis residential services exist, it is not walk-in rapid assessment triage and short-term observation. So it not clear still on the intent.
So Representative Warren, you feel like there need to be more residential beds, residential care beds for over 24-hour stay.
Yes. For
And that's the
people-
intent of your bill.
That is my intent. For people who are in crisis, but they do not need emergency room and they do not need county jail. That is exactly my crisis. That's my crisis, and that's my suggestion.
Do you see the living room stabilization units as part of that solution or independent or not in your vision?
I love the idea of that sort of model, as long as, one, we have enough to serve the whole state. I can tell you that police officers basically north of Freeport, Brunswick, are not going to have time to come to the Cumberland County living room with
Yeah,
folks
and I-
that they have. But if it could be a model that serves the whole state, I think it's part of the solution. But I just don't feel like we should be spending the funding on that when we still don't have basic crisis response across the state. But is it a part of the full solution if we have unlimited funds? Absolutely.
Betsy Sweet?
Thanks. I just was trying to clarify. I think there are two different services, and the one that Representative Warren put in her bill is additional support for CSUs. And I think there's some good work that could be done with hospitals about using them more as step-down units as well. And then there's an additional thing, which is the living room model, and which is a new thing, which isn't established, it's not established yet, which wasn't established at the time the bill was written, which is exciting. And I think that's outside of this bill, although I think if the bill was written today, we could add that to the bill and as an additional thing, but it's different than the CSUs. And so I think the CSUs need support, and I think the living room model needs support.
I just have to clarify, the CSU does mean crisis stabilization unit, which is not what we have. We have crisis residential.
And so
Sorry.
We need to add that to Part C. First line of Part C needs to include the word residential to reflect the intent of the author anyway, or the sponsor.
Yes.
So does that get a little bit more clarity for you, Anna?
Yes, can I just ask one more question? I don't really want to go here, but I'm going to do it anyway. So Dr. Pollard talked about the difference between a CSU and the residential in terms of peer support. And I understood her to say that peer support was a big part of the CSU model, but not so much a part of the residential model. So I just want to make sure that when you look at this, you understand that this includes all of that peer support stuff. I'm not making an argument one way or the other. I'm just making sure that you all know that, and I believe that was the intent of some of the folks that testified, the proponents, that peers be a part of every part of the system. So I just want to make sure that A, I understand it, and B, if I do, that you do as well.
And to whom is that question addressed? My understanding is the committee.
Who knows?
What? Who knows?
Who knows?
So my understanding is the committee is pretty invested in peer support being a crucial piece of any successful models that we put out there in whatever venue there's evidence-based medicine for participation, or evidence-based information for participation. And if, so Dr. Pollard, would a residential care facility that didn't include peer support be satisfactory to the department?
So we are happy to look at peer support as part of the reimbursement model for residential. It does not then make a residential facility a crisis stabilization unit,
No, no,
which,
understood.
right,
Yeah,
okay.
understood.
Because I do have to just point out, we'd still be missing the very key component of the 24/7 walk-in rapid assessment triage, which is not in existence currently
That in this bill.
or in reality.
Right, but if we're heading down that path.
Mhm.
And can you speak to the number of these living rooms that you want established around the state?
Yeah, I think it's fair to have them in each of the crisis regions. Some of them, it may be appropriate to have, either more than one or a larger kind of capacity.
Okay.
But I do think they need to be around the state.
All right. And Representative Zager.
Thank you, Mr. Chair. In the spirit of reducing confusion, there's another thing that I don't quite understand what it means. It's on line 37. It's Part B, Section B1. I don't know what cost settlement is. Perhaps somebody could explain that. It says that beginning this October, the department, when a new contract is established or a renewed, department shall include in each contract a mechanism for cost settlement.
Yeah, the contracts already include a mechanism for cost settlement. The cost settlement refers to the department essentially paying expenses after subtracting out revenue. So as opposed to a bundled rate or a fee for service rate, cost settlement is a contract mechanism where there's an agreed upon budget for how much something should, be estimated to cost, how much revenue is anticipated to be realized, and then making payments on a regular interval against that estimated amount of what the gap is between cost and revenue. So the contracts for crisis services used to be 100% cost settlement mechanism. And I think in 2016 or 17, the department changed to a fee for service model. In 2019, I believe we shifted to an ancillary component, which is a form of cost settlement, and we've gradually adjusted that portion of the contract upward over time, so that the current crisis contracts up to half the value of the estimated amount needed in the contracts comes from cost settlement. The rest of it is more of the reimbursement model
Does this language get in the way of anything the department's doing now or would do in the future if this was passed by this committee?
Yeah, it's hard for me to potentially, yes, because there are models that are allowable with an enhanced FMAP that CMS has introduced under ARP. That's for a bundled rate, which is not cost settlement. Right. And there are also models that we are very much interested in that have a prospective payment a prospective payment system, which is also different than a cost settlement mechanism.
So let me go to the sponsor and ask if you would be okay with replacing that particular language with language that reflects current budgeting standards by the department, or current reimbursement practices in the department.
Yes, thank you.
So does that leave you enough flexibility, Dr. Pollard, to live with that phrase, since we're already recognizing what you're doing and might do?
Sounds good.
Any other questions? So Anna, are you good with understanding the amended version that we're about ready to vote on?
I still have two questions. The first is E911. And the
Well,
second,
911, I thought that was a given. It comes out at the request of the
okay,
sponsor. So
just
unless
making
anybody
sure.
wants to push back against 911, we'll just take that one out.
Okay, and the second is just that I can work with the department.
Absolutely, that's carte blanche. Representative Griffin.
Thank you. I'm sorry. I'm just going to need clarification on can I just have the amendment kind of listed again, so I just have a clear idea. I kind of feel like I was going around in circles, taking notes and everything.
I don't know why you felt that way. Everybody else in the room did.
If you don't.
There's more on
if
a path
you
than the
don't
rug. Okay. So Anna, do you want to summarize the amendments, please?
I will have a stab at it. So the first is removing E911. And then the other thing I heard was that that Part C would be reworked to say that it's residential services, crisis residential services rather than stabilization units. I think that also needs to be in Part D in line 6. And in fact, you might want to even include both residential and the stabilization unit in there. That would be a choice for you. And then there needs to be some changes to Part B that I'm not entirely clear on, except that the intent is to make this language look more like the current budgetary practices by the department, and that's why I would need to work with the department.
So Anna, you just referenced the portion we haven't actually discussed. Can you tell me where we're talking about again?
Parts D, you mean? That's the public education. So that would be spreading. Is that what you're talking about?
Just before that, you referenced including crisis stabilization unit and residential in a phrase.
But that was Part D. Part D is the public education section, okay. And it just says to ensure widespread knowledge of the availability of mental health peer support, crisis lines, crisis intervention, mobile response, and crisis stabilization unit services. Given that crisis stabilization units in every other part of this bill is actually supposed to be residential, I would assume that that is also residential. And I just wanted to know whether you wanted both in there, because you will have a crisis stabilization unit in the near future.
Would the sponsor accept crisis-related services, community-based crisis-related services?
That sounds great. Thank you.
Does that help, Anna? We can just strike the list and put in that phrase.
Okay.
Representative Griffin, how are we doing now?
A little bit better. Can I just ask Dr. Pollard how she feels about the amendment? Is that okay?
I appreciate the consideration of my feelings. I'm struggling to follow it. I'm more of a visual person. I think as long as there is flexibility, and it sounds like we're all in agreement that peer support is important, it would be helpful to continue the idea of a public education component. Sounds like the intent is to increase residential beds and to have some flexibility for consideration of what are truly crisis stabilization units, which is the 24/7 access with up to 24 hours of support. The part that gives me pause is, depending on how it's worded, the requirement to increase crisis residential beds or funding is a little bit of where I have pause, simply because I think that is a significant portion of spending already is on crisis residential. And I think that if we are successful in having more robust mobile services, as well as what is truly CSU with that shorter term support, I'm not confident that we would continue to need, or that we would need to expand bed capacity. We have some regions in the state where those beds are underutilized, and we have some regions in the state where they're at or above occupancy. So I think the wording and consideration of the intent of that section is really important, and I'm not entirely clear on it.
Okay, let's go back to that language. I think the way I understand the bill as it stands now is this gives you flexibility to use that money where the department feels it's most appropriate. And if that's increasing residential beds in District A and decreasing them in District E, or 1 through 8 or whatever the nomenclature is, then I don't think anything about the bill constrains that.
Gotcha.
Senator Moore.
Thank you, Senator Clarkson. That was my question. I guess I'm not seeing in the bill where we were specifying to add additional beds. So that's why I was looking for it, trying to see where that was.
Well, that comes in section C, if I'm remembering correctly, of the various sections. And it says strengthen mental health, and we've added the word residential stabilization unit services. And there's an appropriation with that of $1.3 million. So that's part C. Once we clarified that the author or sponsor was talking about residential stabilization units, then that comes with a price tag of 1.3 million, the way I understand it. I'm looking for a head nod from the sponsor. I got a head nod from the sponsor for those of you who are not watching.
And I think that would also be that expansion would be limited to the amount that you have in the appropriation. I mean,
Based
of the
on-
1.3, because that's what you have in the bill.
Based on these dollars, right? Yes. Does that answer the question, Senator Moore, as to where that came from?
I do, but of course, what I'm reading it is to say provides funding to strengthen the mental health crisis stabilization. Well, we're not residential services in order to provide services. It doesn't necessarily call for beds. So I think that would leave the department to use the funding as they see necessary. Is that how I'm interpreting?
That could be personnel as well as beds, or
Right,
instead of,
exactly.
or yeah. No, I
Yeah,
think that's a good
exactly.
point. That's a good
Exactly.
point. Okay, that leaves the department even more flexibility.
Exactly. And that's what I think we should leave it to the department to, because they're doing such good work right now. And if we can help a little bit with the funding to even expand it to more of what their plans are, I think that's important.
Okay, Anna, you've about used up your quota of questions. Are there any others?
No, I do just want to say that this does specify peer support. I don't know how much the price tag for peer support is, but it may be that, most of the 1.3 gets used up for that purpose and not for beds. I don't know. So yeah, I think the flexibility is there.
Okay. Are there any other questions you feel comfortable preparing for review, for language review with some help?
I think I'm good.
Okay.
You'll be relieved to know.
I am. Yeah, I am. I'm relieved. All right. So there's a motion on the floor related to LD 1586. Ought to pass as amended. Are there any other comments, questions, concerns? Then we'll turn it over to Carrie to run the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry. I'm sorry, you're muted.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
So at this point, I'd entertain a motion on LD 968. Yes, Representative Meyer.
Thank you, Mr. Chair. I would move LD 968 ought not to pass.
And I'll second the motion.
Thank you, Senator Moore. Any discussion of that, since the intent of the bill that was submitted in November, December has been rolled into the bill that we're currently marrying it to? Okay. Yes, Representative Meyer.
Thank you, Mr. Chair. I just want to thank Representative Supika for bringing 968 forward. and being a part of this important discussion that we've had here today. And thank you very much.
Thanks for being here and thanks for answering questions and raising this issue.
Yeah, can I add one little tidbit of information for you all to consider going forward in the coming months and years that you serve on this committee? Thank you all for your work here today. And I want to thank Representative Warren as well for her work on her bill. But just when you're voting in the future, I think Wade Betters of the Bangor Police Department gave a really great testimony that if you haven't had a chance to read it, to give it a read, in which he talks about how they could really do with a minimum of 2 to 4 staff to be of support to the PD to be able to respond within 30 minutes. And that would be like great assistance to them. So any opportunities that we can to support our police departments is greatly appreciated. And I wanted to thank you all for your time today.
Thank you. Senator Baldacci?
I just wanted to join in that recognition. Representative Supika, on her service to the city council and now as a state representative, has done a lot and has really brought these concerns to the fore. So I really appreciate her work. I did read Officer Betters' testimony. I did think it was very helpful. I'm glad we're able to pass it today. I just wasn't sure about the fiscal piece, but I think that the committee's reasoning makes a lot of sense. So I'm happy that we're able to move forward today, but thank you, Representative Supika, for your work. And I know it's very important to Bangor, considering some of the challenges we have to face. So thank you very much.
Okay, so there's a motion ought not to pass on LD 968. We'll turn it over then, and not seeing any further comments, to Carrie to collect the vote.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci.
Yes.
Senator Baldacci. Yes. Representative Perry.
Yes.
Representative Perry. Yes. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. That's 10 yes, 3 absent.
So Representative Zager?
Thank you, Mr. Chair. Just wanted to pass on a message. Representative Warren's computer died. She wanted to thank the committee for the time and effort.
And if she can hear us, this has been the source of a very interesting and informative conversation, a chance for the department to brag a little bit and lay out its plans for the future, all of which are good. So I would now entertain a motion to have a lunch break. So we can have a break and then get back to our morning work. So how do folks feel? 1:15? Any comments?
1:15, Mr.
All right.
Chair.
1:15 is the only person who spoke up. Any opposition? All those in favor of taking a break until 1:15, please hold up your palm. Thank you, folks. And thanks to the sponsors for being here, and to the advocates, and to Dr. Pollard for helping us sort through language barriers complicating an already complicated process. Thank you.
Thanks for the opportunity.
Very good. See you at 1:15. Um. So it looks like we have an adequate complement to begin our afternoon work. A little bit later than anticipated, but overall we've been doing pretty well for a legislative team. I think the next step then is to move to consideration of LD 1624, since 1427 has been moved to a Thursday conversation.
Aren't you happy to have an easy bill to?
Well, if everybody would submit perfect bills, Representative Craven, like yours, our work would be a lot easier.
That's right.
I confess, Representative Craven, I did have that thought as I worked on this one. I'm like, oh my gosh, an easy one. Okay, LD 1624 is a resolve to create a stakeholder group to identify the needs of long-term care family caregivers. This resolve requires the long-term care ombudsman to establish a stakeholder group to consider and make recommendations for the implementation of an assessment measure for the needs of family caregivers providing long-term care services to family members, and to establish a plan to improve referrals to services. The long-term care ombudsman would invite the participation of representatives of the department, of the area agencies on aging, service coordination agencies for recipients of home care services, legal services for the elderly, Disability Rights Maine, and the agency designated by the state to provide statewide assessments, which I believe it's Maximus, as required by CMS, family caregivers, and any interested parties. And the long-term care ombudsman would submit a report to this committee no later than January the 2nd of 2022. The long-term care ombudsman is in support of this, and she talked about the T-Care assessment in Washington State, and that the stakeholder group would consider the implementation of T-Care as that assessment tool. There were some requests for additions to the stakeholder group. Northern Light testimony said representatives of hospitals and home care service providers for service coordination, and you heard from Home Care and Hospice Alliance. They requested their presence as well as a provider of in-home care. I do want to remind you that if you want to add the alliance, it's the representative of an organization who represents language, not naming them. And then the department is in support. This aligns with ODE's work and the Older American Act's reauthorization of 2020, which requires a family caregiver assessment to be implemented as part of the National Family Caregiver Support Program administered by ODES and operated by the area agencies. And so ODES will collaborate. Well, they'll be in collaboration. If person can't type, ODES will collaborate with the Long-Term Care Ombudsman Program. And we haven't yet received a fiscal impact from OFPR. I don't expect a fiscal note, but we haven't yet received it.
Very good. Are there questions from the committee related to that analysis? Thank you, Anna. The only question I have is my brain still uses long-term care as being almost equivalent to nursing home. And I want to clarify with the sponsor that we're talking about people who are invested in care over the long term, not long-term care.
Right.
Okay. Thank you. So we have somebody who's a convener. We have somebody who's going to support the work. Representative Perry?
Well, not to rush anything, but I'd like to vote ought to pass with the addition of the 2 recommended people to be added.
I would second that.
We're not going to debate the value of the bill from Representative Craven.
No, it's a perfect bill. We should have thought to have included those two entities to begin with.
And I think the motion speaks to that.
Okay, so there's an ought to pass motion on the floor as amended, and it relates to LD 1624. Is there addition, comment? Yes, Representative.
Sorry.
Who's tired? Who's tired?
I
Anna?
know. I just want to make sure. So Northern Lights suggested a representative of hospitals and a representative of home care service providers. And the Home Care and Hospice Alliance asked for the alliance as well as a provider of in-home care. So I think that's really three. It's the hospitals, the in-home, well, maybe it's even four. It's hospitals, home care service providers, and a representative of home care service providers, which is not the same thing, and a provider of in-home care. So obviously, if you don't catch them all, it does have any interested parties, but I just want to make sure that you realize that there were more than two.
Any thoughts about that from the committee members?
All inclusive is good.
What did you say, Representative Craven?
I said all inclusive is good.
Yeah. Yeah, and as long as it includes other interested parties. Representative Perry? Did you have your hand up?
I was going to just say, a home care provider and somebody who represents home care providers, is that going to be, or are we looking at a different category? I'm trying to figure out how we separate those categories out when they are all about home care.
And I think one is the people doing the work at the bedside, the DSP, and the other is a representative of a advocacy group.
Right. It's the advocacy group and versus one of their members.
Right.
Yeah.
Yeah. That's how I would interpret that. So are we adding 3 people or 4? 4. We're adding 4. Okay. So there's a motion on the floor, ought to pass as amended 1624. And seeing no further discussion, we'll move to carry for the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you.
Thank you, Representative Craven, for bringing such a sterling bill to our consideration.
I think she's had a little bit of experience with this, don't you?
Yes, we all have different lived experiences, and she just brought hers. All right, so we can move to consideration now of LD 854.
Okay, LD 854 is an act to ensure continued school-based services for children with disabilities. This bill directs the department to provide medically necessary, putting in the correction at the public hearing, medically necessary school-based services in developmental preschools for children from birth to 5 years of age. It designates any rules adopted as major substantive, and it requires the department to convene a stakeholder group when drafting the rules and take into account the findings from the independent review of the state's CDS program that is being carried out pursuant to a budget initiative. You heard from the sponsor that January 2020, there were new proposed Section 106 rules. This was a new section of main care that was proposed to consolidate school-based services into one rule that prompted concerns about reductions in services and rates, and the rule was recalled. A similar bill, 2141, was passed out of committee in the interim, but there was no session for it to be enacted. This bill requires the rule to be made substantive and to convene a stakeholder group, and young children receive CDS services as currently supplemented with Section 28 or 65 main care services, and Section 106 would have limited those services to the hours on the IEP. The department testified that they were planning for the new rule by the end of this year, and this will delay adoption to allow time for education and training before it. And they will delay adoption of the rule to allow time for education and training before it takes effect. This major substantive rule requirement for 0 to 5-year-old services in schools impacts multiple sections of main care policy, which would be a burden, including for school budgets. And they argued that they are involving stakeholders in monitoring the CDS study. You heard from the Disabilities Council. They are neither for nor against. The study in the budget, I thought I had fixed that problem. The study in the budget, Nancy Cronin is the chair of that advisory committee, which was assisting the legislature in the provision of the contracted study and advising the education committee. And she mentioned that one of the 4 recommendations is the centralized billing system, that there's currently 2 systems of funding and sources of funding, and that's very confusing for schools. So just a reminder that the italics for the medically necessary was a correction. As drafted, it included all Department of Education and CDS, which was rather than those that are provided by DHHS. That one's on me, I made that mistake. The other question was whether all these services are provided outside of development, whether there are any services provided outside of developmental preschools that this applies to, whether this new rule would apply to other services or children, as opposed to just developmental preschools, and I don't know the answer to that. I do have an update about the education committee around the CDS study. They had a meeting yesterday to determine what they plan to move forward with for their public hearing, which will be on Friday. And so I talked to Hillary, who staffs that committee, along with Sam, and she said that they discussed the report and the recommendations on Monday, and they are moving forward with a couple of bills. They ran into a sort of an odd problem with their authority for reporting out a bill being to the first regular session, and we're now in a special session, so they are using different vehicles. But my understanding is that they will have 2 bills, and one of them relates to the single billing issue that Nancy brought up, and the second is improving child find, and that would be that's one of the bills that will have a public hearing on Friday, and that language includes a report back on February 15th to both education and to this committee because of the child find and the single billing. And then the second substantive bill is about moving the 4 and 5-year-olds to school districts that are currently under CDS and DOE. So the proposal was to move the 4 and 5-year-olds to school districts and the birth to 3-year-olds under the DOE rather than CDS. That will also be at a public hearing on Friday. The language that is going to be heard on Friday is still being worked on. It requires an extensive rewrite after the discussion that the committee had yesterday. So that's the update on that. Representative Lemlin had asked about the examples of preschools. So that's why that list is there. It's by no means all of them. I didn't try to find all of them, but that was just for some examples. And we haven't yet received a fiscal note from OFPR.
Okay. Any comments, questions from the committee? I see the sponsors here. Any comments, questions from you? Representative Meyer?
Thank you, Mr. Chair. So I am very grateful to Molly and the department for their work around an amendment and arriving at a mutually agreeable compromise. I will draw your attention to where we're at. As we know, the bill, the original bill designate any rule adopted as major substantive. The agreement reached is that it's the first iteration of this new rule is major substantive, and that future rules are routine technical. This is essentially where we had landed in the last session. It maintains the stakeholder engagement requirement. And I believe that we've got both Molly and some of the advocates here to help us with some of the outstanding questions around language and some of the other issues that Anna may have brought up.
Molly, do you want to start first?
Sure, and I greatly appreciate Representative Meyer and the folks working on this bill's willingness to have this conversation. Jennifer Patterson is our policy director for Maine Care, and she's in the attendee list and can speak to the nuance of some of this work far better than I can if we could bring her in. And then I know that she and her team have been working on some of the questions that we had from Anna around drafting, but if you have, it might be helpful for you to ask specific questions for Jenny to respond to. Thanks.
Welcome, Jennifer Patterson. You've been listening to the analysis. Do you have any comments or ways you could be helpful without further questions, which you'll get shortly?
I will do my best, and yes, thank you to Representative Meyer and to Molly. And we have been happy to work on a revision of language. I know there was one question that Ms. Broom had noted with respect to developmental preschools that she did not know the answer to. And what we had thought in looking at the language was that that actually is not really a term of art, and maybe that was creating additional confusion. So that the intent, as I understand it, is to have these services be available to all students in that age set, so that removing that term might make it clearer that that was the intent. And let's see. Well,
would it be easier if we
I
just questions?
I think it might be. I'd be happy to answer questions. I know that Ms. Broom had some questions, but I'm not sure which ones she thinks it would be most helpful for me to speak to.
Start
So
with the committee member. Representative Lemlin, you had a question.
Yes, thank you. What services are we talking about specifically that are not currently being provided?
yes, thank you for the question. I think that the thing that makes it complex to adopt a school-based services policy is that from a Maine Care perspective, these are services that are actually governed by many different sections of the Maine Care Benefit Manual. And so they exist under other sections of policy, and the intent in adopting the specific school-based services policy for K-12 as well as for this younger age group is to specify the process through which those services can be, the determination of medical necessity can be made through the IEP. So I think that the specificity of what we would be looking at in adopting this section of policy specifically for the preschool age would be to just articulate with precision exactly how those services such as physical therapy, speech behavioral supports. All of the services are being provided, but the process for reimbursement is complex because of the overlap between federal Medicaid law and federal education law.
And one more thing, Senator.
Please.
So I didn't know that there was a cutoff for Medicare or Medicaid at a certain age. So you're telling me that until they reach kindergarten, there are no services covered?
No, Representative. I think under traditional main care, those services would be covered if that was a child who was a member of main care. I think the question is the delivery of the services in the school setting specifically and what the procedure for that looks like. So under the federal IDEA, if there's a service that is needed for the child to access their education, then it is included in the IEP, and the school district or the school can actually seek main care reimbursement for delivering that service in the school setting. But the service is available.
Okay, one more, Senator. I'm sorry.
No, go ahead.
I thought sure that all these things would be covered in an IEP. I can't imagine that if a young student, regardless of their age, if they needed PT or OT or speech therapy, I would think that the team would put that in an IEP. I mean, to me, that would be mandatory. Are you telling me that that's not always the case, ma'am?
Again, I think to the degree that there is a service that is a covered service under main care that has been included in the IEP, then it is permissible to have that be billed. It's really up to the district whether to seek reimbursement for that service through main care.
Well, let's get some more questions answered, and we'll come back to Representative Lemlin to make sure he's gotten the answer he's looking for. I see, Ms. Cordes, can you jump in here and help us? Welcome.
Good afternoon, Laura Cordes from Maxby. I'm joined this afternoon by Tiffany Haskell, also of WABAN and Maxby's Children's Committee, and Representative Lemlin. I think Tiffany can also explain as a direct service provider what is currently being provided, but what's at stake now that we have both the Department of Education and CDS making reforms, while we concurrently have OMS and the department looking to make changes in a new rule that would combine services under Section 65 and 28.
So you've been teed up there. Tiffany Haskell, welcome. Do you want to try and answer some of those questions?
Sure. The proposed Section 106 that was pulled by the department last year, yes, its purpose was to place the school-based rules, place all main care rules in one section that could be billed in schools. But relative to things like speech OT PT, there was no impact. Rather, Section 106 directed the reader to those sections for accessing those services. So what was a significant change with the proposed 106 was in the area of essentially medically necessary behavioral health supports that are largely currently provided under Section 65 or 28. And many public schools access that main care funding to support their programs and services, and many do not because of the many layers of requirements that go into operating that program, and also because of being nervous on the billing side for an audit that they had seen other districts not meet those standards and have to pay back a lot of money. So the idea to have one main care rule where school-based services are reflected is conceivably a good one. But with those questions about things like speech OTPT, there was no change within 106 relative to those services. However, it would have necessitated completely removing day treatment from Section 65 and completely removing center-based services from Section 28. So it's those services that are at the crux of the 106 debate that exploded last year and resulted in a very large group of interested parties all agreeing to put the brakes on that. But the ask in the end is one to say, with that 0 to 5 age range, there is so much going on. The DOE, the Education Committee, as you heard, just met yesterday as it moves through its process of considering further the public consulting group report on the early intervention system, right? So you have that whole massive moving part. You've got the moving parts with 106 that will come back up. The reason that we ask for the carve out for major substantive for that young age range is that the other thing that 106 did not do was change program services and rates for these behavioral health services on the K-12 side, other than for one small piece. However, on the early intervention side, in its original form, it would have cut rates nearly 30% and cut services in terms of how much frequency, duration, and whatnot by about 65%. And so understandably, there was a lot of concern. Subsequently, 106 was pulled. LD 2141, LD 1241, excuse me, I think was the number, was approved unanimously in committee, but the legislation didn't reconvene because of COVID. Hence, we have 854. The ask has been clarified to be major substantive only for the first iteration of the next version of 106. And with all of the moving parts that are converging on these early intervention services right now, the ask to make this age range a carve out for greater consideration, oversight, participation by the legislature is essentially what we're asking.
So in essence, it represents a process question, not a content question.
I would say so, yes.
Okay. Representative Perry?
Thank you. Well, I'm thoroughly confused with all the numbers and the LDs and the, so I guess what I'm really trying to sort out here is, are you trying to make the system more user-friendly? And that may sound crazy, but school districts are not used to doing medical billing, I can tell you that. And if you're putting this kind of medical billing into the school systems, is this going to simplify it, or is this going to make it more complicated?
So I think that question is about perhaps what might be proposed by the department in the section 106, but that's not anything to do with LD 854, which is just carving out the youngest children to be major substantive from this larger picture of the work that is. This bill 854 for the carve out of this young age range doesn't have anything to do with that centralized billing question piece on 106 that was brought up in the testimony.
Okay, so what are we carving out? I guess my question is, now I know that CDC services have been under Health and Human Services, and you're carving out the 0 to 3. Is that what you're carving out of the school system? Or are you carving it out there?
No.
If I may.
Maybe we want to look at exactly what the bill says.
Did you want to jump in here, Ms. Cordes?
Thank you. If I may, the carve out is really to say under normal rulemaking process, where something would not be major substantive, meaning coming back for legislative review, we're asking for the opportunity as the department moves forward in making a new rule combining current sections of service for children, that it would come back to this committee for review after they move forward with a proposed rule. That's the carve out, so to speak, not to propose what's in that rule, but to simply say this population is so important that we get it right. There's so many changes happening with 2 different departments, 2 different committees, that we would like the opportunity to make sure that we've reviewed the impact for this population at a future date after the department moves forward with the rulemaking process.
Does that answer your question, Representative Perry?
Let me just rephrase it to make sure I do understand. So essentially what you're asking is that instead of just routine rules, when it comes to working with this age group and the rules that the department has around this, that these rules will, for at least one time, become major substantive.
Yes. Exactly that.
Carve out has different connotations in the
Yeah.
medical world, and I think that confounds a number of us. So, okay. So what you're doing is designating for major substantive rulemaking a portion of the rules that are coming out of the department. It doesn't sound like it interferes with the department's process in promulgating the rules, but it gives the public an opportunity and the legislature an opportunity to go review the rules that have come out of this process. Do I have that right?
Yes, Senator.
Okay. So let me come back. So Jennifer, does this, I'm sorry, I don't know how to refer to people anymore when I'm tired. I want to say Ms. Patterson, but I probably should just say, okay, Jennifer Patterson. Does the department feel at all constrained by 854 in doing its work?
Thank you, Mr. Chairman. And I wanted to affirm, kind of consistent with what the sponsor expressed in the conversation. I think the only concern that we would like to express, and really I think it's a decision for the legislature, is on the timing, because having this be major substantive may make it take longer than it otherwise would. As Director Probert testified at the hearing, we are intending to move forward with this rulemaking, and we are doing so in consideration of all of the issues that were raised last year. So we do think that we'll be able to address them. However, given the complexity of the situation and that we have the study going on in the Education Committee, and I believe the intent of this bill to look specifically at that younger age group, I think if that is the choice of the legislature, then we're comfortable going forward with the major substantive for that age group. Our original concern in opposing the bill was that there was a lack of clarity as to whether every single type of service that might be delivered in this setting would require the major substantive rulemaking. And I think with the amendment that will be clarified.
Okay, and so you're not asking specifically for an extension of how long you have, you're just saying that to do this work will take longer.
I think that as it's laid out in the bill with kind of the specificity of the manner of engaging in the stakeholder consultation, and just doing a major substantive rulemaking takes longer than a routine technical rulemaking. So for those reasons, it would take longer. But I think that is a decision that's up to the legislature.
And I think there's a lot of advocates who think that time would be well spent to doing it more deliberately and giving chance to review the process. All right. We haven't heard from Molly yet. Have to hear from Molly. Any other comments that you want to add?
No, Jenny represented as well. Thank you.
Very good. Are there any other questions? Okay, so at this point, we're looking at a bill that creates an opportunity for review of major under the major substantive rulemaking process, to look at a portion of the rules coming out of the department to address what was a hot item last session in section 106. And any further discussion? Then I would, Anna, before we do that, are you comfortable that you have a handle on the amended version?
Yeah, I still have a couple of things to work out with the department, but that's about the wordsmithing, not about the concepts.
Okay. Remember I said carte blanche, so work away. All right, so at this point, not hearing any questions, it sounds like it's time to entertain a motion. Representative Perry?
Yes, I'd like to move LD 854 as amended.
Off to pass as amended.
Second.
That's been moved and seconded. Is there additional conversation about that? I'm not seeing any. So I'll defer to Carrie to collect the vote.
Representative Zager. Senator Claxton, it looks like Representative Griffin has a comment.
Oh, Representative Griffin, I'm sorry.
I apologize. Can we just have a quick corner caucus? I think my caucus has some questions. I'm sorry.
Yep. Absolutely.
Okay.
So 10 minutes?
Oh, probably 5 is probably good.
Okay.
Thank
The
you.
representative had promised 2 o'clock and we'll be back at 2. We'll be a slight hold until then.
We promised we'd be back by 2. We're back.
Hey, I just,
Early. That's right. Did you have your hand up again, Representative Griffin?
I
Okay.
just wanted to say thank you for indulging us to be
Yeah.
able to do that.
That's part of our the committee doing its work, so you shouldn't hesitate to ask, and hopefully you haven't. All right. We haven't voted yet, so are there additional questions or concerns? This is a significant change from the original bill. Okay, so the motion is ought to pass as amended. The amendment limiting consideration to a process question. All right, Ms. Withy?
Representative Zager,
Yes.
Representative Zager, yes. Representative Lemlin,
Yes.
Representative Lemlin, yes. Representative Stover,
Yes.
Representative Stover, yes. Senator Baldacci,
Yes.
Senator Baldacci, yes. Representative Perry,
We don't see or hear you, Representative Perry. Oh, we still don't hear you. We got the seeing part down. We don't.
I'm here, yes.
Representative Perry, yes. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor, Representative Connor is absent. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan, Representative Madigan is absent. Representative Javner, Representative Javner is absent. Senator Moore,
Yes.
Senator Moore, yes. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Thank you. So we should thank our guests, Laura Cordes, Tiffany Haskell, and Jennifer Patterson, for being here and helping us understand a little better the changes in the bill. So thank you for that. Did you have your hand up, Laura?
I just wanted to extend my thanks to you, Senator, committee members, Representative Meyer, and certainly the department for working together on compromise language. Thank you very much.
Helpful to have knowledgeable people in the room. Thank you. All right, Representative Meyer.
Yes, I would echo Ms. Cordes. Thanks to the committee and to the department. And you might want to consider keeping Ms. Cordes here with us, as she is also a stakeholder in the next LD.
Very good. All right, so that lets us move to consideration of LD 1574.
All right, LD 1574 is an act to ensure support for adults with intellectual disabilities or autism with high behavioural needs. This bill requires the department to establish by rule reimbursement rates for positive behavioural support plans and behaviour management plans provided to persons with intellectual disabilities or autism. The rates must be adequate to cover all parts of the plans, including clinical oversight, equipment, and staff with additional training, qualifications, and experience required for managing challenging behaviour or preventing a personal crisis. The rules adopted are made substantive and must be adopted by July 1st, 2021, and this is an emergency bill. The proponents argue that the current rate structure is inadequate. There used to be a behavioural add-on, and that is no longer. And the small MaxB provided study of costs for supporting individuals with these plans showed that they exceeded costs because of oversight qualifications, home modifications, higher DSP turnover, and decrease in reimbursement because of 2-to-1 staffing ratios. That's 2 staff to 1 client. Support needed exceeded what is allowed, and DSPs and program managers are paid the same regardless of whether the client has behavioural challenges or not. Providers are ill-equipped to serve some clients and can't afford to take clients with behaviour management plans or positive behavioural support plans, and so those clients end up being discriminated against, and those plans can also take a long time to develop and require trained staff and frequent professional review to avoid behaviours that put everyone at risk. You also heard from some of the proponents that this recognises the continuum of care model that meets each client where they are. There were some requests to amend, allowing for an emergency adoption. A major substantive rule, as you know, requires legislative approval. This requires the rule by July 1st, 2021, and that could only happen if they were allowed to adopt by emergency. And the rate structure to ensure equal access without incentive to remain on restrictive plans any longer than necessary. I think you heard the idea of a possibility with a behaviour management plan as an incentive to keep people on those plans because the rates are higher. There were other requests to amend, adding access to a psychologist and behaviour analyst services for developing and overseeing positive behaviour support plans. Those are currently limited to 16 hours a year, and that limitation doesn't exist for other populations than the developmental disability. Disability Rights Maine have concerns that there is a stigma attached to the behaviour label, and creating the incentive for the behaviour management plans that are supposed to be temporary, and recognising a need for more clinical support, and the department is exploring different modalities of support. The department is opposed. The timing is problematic as the state works on crisis services with the START program and extending the contract for assessment of addressing behavioural needs, with the results of that later this year. The value-based purchasing idea included in the rate evaluation with rate increases in the meantime, and there is a need to reward for reducing behaviour and ER or law enforcement interactions rather than rewarding for behaviour plans. And this is drafted to apply to any service provider with those plans, including ICF, IIDs, PNMIs, and home and community-based services. And they don't think that was particularly the intentions. In other words, that's a drafting note. And the date in the bill is not realistic. So the drafting issues that's again why there's so much testimony on this bill analysis, because that's where all the drafting issues have been pointed out in terms of applications, the date, the issues that Disability Rights Maine and others have pointed out regarding incentives, and also the limitations on plans and provider types. There was, as you know, a study of this issue that this committee had requested and was enacted in Resolve 2019. That study you've seen a number of times now, so I had linked to that. You also asked for the department the information about the UNH START program information. And you also had some other questions for the department, and I see that Paul is here. And you had also asked for the wage increases again for Section 21 and 29. So you had received that last week, so I had sent that again. I am going to go to a different screen. I think I have to stop sharing to go to it. I want to show you the START. This is the information that you also received from the department about the START program. And I'm certainly not going to read it to you because obviously Paul is here, but I just wanted to remind you that you also received this information about the START program, that they are going to look at the way that they support individuals with IDD and mental health issues in the community. And this is around the changes in the waivers and so on. So I'm going to take that down, but I just wanted to remind you that it was here. And you also have, I don't know if you can see that or not, if that worked, but that was the other sheet that you received with the support, the recent supports in the budget for Section 21 and 29 that you had asked.
We're still looking at the START memo.
Right. So let me just do that again. Okay. So that's the recent support for Section 21 and 29. You've seen this chart a few times now because it has come up with all the rate bills, but I just wanted to remind you that that was there because you had asked for that. But I do know that Paul is here in addition to Molly, so you may want to ask more details about the START program here.
Let's start with committee members and see if they've got any questions or comments related to 1574. I'm not seeing any. We haven't been yet joined by Director Associé. There he is. So we'll see if he has a comment to bring to this, and then we'll go to Molly.
While Paul is joining, I can tell you to just skip right over me.
Okay. All right. Welcome, Director Associé.
Thank you, Senator Claxton and Representative Meyer and members of the committee. Glad to be here to answer any questions you have. I'll just very quickly summarize our position that we discussed at the hearing. We are working on how people with challenging behaviors are served in our system. We think there's a lot of work to do. We're not entirely clear on what all that work is. We think that this puts the cart before the horse, essentially. We need to understand what the gaps in our system are before we start talking about what we're going to pay for differently. So that's essentially our position, and I'm happy to answer any questions about the information we submitted or any other questions you have.
The only question I had was about the start. Is that in a contracted phase or contracting phase?
We have an existing contract with them, and we are amending it to add this scope of work. Currently, what they do since last year is train and certify our state-operated crisis workers. And so we're amending it. We don't anticipate any issues with the amendment.
And is there a timeline for their work being finished and you having a chance to figure out where to go next?
Yes, they estimate this assessment to be about a 3-month process. We'd like it to start by July, so July, August, September. So we should have the results in October.
So that would allow us to have some more information to work with, or some direction or sense of direction that we don't now have if we wanted to bring it up in January.
Yes, I think that would be much better timing. We'll also, of course, know much more about federal HCBS money and what it can be spent for, et cetera. So we'd be in a much better position to recommend something to you then.
Okay. And Representative Zager?
Thank you, Mr. Chair. I'm wondering, in light of what Director Associate just said, how much room we have for carryovers, if we might table this and carry it over.
I think that sounds like a distinct possibility and very appropriate in this circumstance. The next step would be to table it, if that's the route we want to go. Representative Craven.
I move to table.
A second.
So the motion to table has been moved and seconded. All those okay with tabling, please show a hand. That is unanimous of those present. Director Associate, you didn't put up your hand, but I assume that you agree. So we'll.
Yes, that's a good move. Thank you.
All right. So we'll. This bill has been tabled, LD 1574, and we'll soon be putting in a request to have this carried over. On our very limited carryover list, this seems like a good use of one of those slots. Okay, because there's some real good information coming. Thank you, Director Associate, for being here.
Thank you. Good afternoon.
All right, that brings us to consideration of LD 964.
Okay, and before I start with this, I do just want to make sure that you all know, especially for the newbies, that that carryover will require a vote. It will be an actual report before we request it. So for those of you that are new, you will have an actual vote on this bill to do that before we do that. Okay, LD 964, this is an act to expand access to certified substance use disorder recovery residence services. This bill requires recovery residences to be certified according to the standards set by a nationally recognized organization that supports persons recovering from substance use disorder in order to receive contracts from the department or receive housing vouchers or municipal general assistance housing assistance from a person living in a recovery residence. The bill also prevents an applicant for general assistance from being denied general assistance for the sole reason that the person is living in a recovery residence. And the bill requires the cost of living in a recovery residence to be calculated in the same manner as for other housing assistance when maximum amounts of general assistance under the municipal ordinance and the amount of general assistance granted to the applicant are established. You heard during the public hearing that recovery residents are having to show municipalities their entire books to allow a person to qualify for general assistance because the applicant can only receive a pro rata share of costs of basic needs of the household. Hotels don't have to do that, but they are not equipped. Hotels are not equipped to deal with substance use disorder issues, and there have been some variance over time in terms of general assistance being accepted for persons living in recovery residences. The MAR certification ensures quality of residence, and you heard a lot of testimony about that. And the department said that the rules for certification are in development. The department contracts with Main State Housing to provide operating subsidies to certified recovery residences, and only MAR certified residences are eligible for funding under that program. The department contracts with MAR to certify recovery residences based on NAR, that's the National Association, and this bill could necessitate an increase in that contract. There are currently 51 MAR certified recovery residences and 70 uncertified. The department also mentioned that they are unaware of anyone being denied general assistance solely because they live in a recovery residence. You also heard from Main Housing. They have been working with the department to run a pilot program. And in that pilot program, those residences must be certified by MAR, and they worked with the sponsor to include the amendment language request that he asked for at the public hearing, which is to include in the amendment to the extent not in conflict with federal law, etc. So that would be new language to be added. The current law in Title V, under the duties of the department, subsection 22 requires the department to adopt rules, and this came up during the public hearing, for certification according to national standards, although the certification itself is voluntary. This bill would require certification for department contracts or Main Housing housing assistance. And that's the section of law there that does that. And you can see that that was a very recent law, and included in that Public Law 2019, Chapter 524 was also this Section 21 that established the pilot program that you heard about for short-term rental subsidies for a person recovering from substance use disorder to reside in a recovery residence. And you did receive additional information, which I can bring back up for you when I've just finished going through this, that you received from Main Housing. They're very quick over there. No sooner had you had the public hearing than they sent over that additional information to answer the questions that you had asked about the pilot project and the need for the amendment. You asked how the MAR board is selected, and the executive director of the board sent this information back about the founding of MAR and its incorporation as a 501c6 nonprofit trade organization. All the members are volunteers, and in 2019 they expanded to 9. In selecting board members at the time, they solicited applications from people knowledgeable about recovery housing, including from affiliates, and added 2 non-owners and representatives of their affiliates. And affiliates are recovery residences that join MAR and become certified. The board is currently seeking new members, and they have an ad hoc nominating committee. They have agreed as a board that they need people who support all pathways, people with a background or interest in recovery advocacy, housing with professional experience in law, finance, healthcare, and human resources, and an appropriate geographic representation. It says they want to make sure they've got helpful expertise on their board, geographic representation, and affiliate representation. And 75% of the board have to have lived experiences. And she said that their bylaws allow for up to 15 directors. Their goal right now is to grow to 11, and they are in the process of changing their status from a 501c6 to a 501c3. I did send you some information on other states. This was for in Oregon, a project, but it had some information on that. And also you asked about GA rates for hotel housing. I did ask Kate, she said that the department would be more likely to have that, and I believe that that the department's general assistance person is here. I'm just going to actually change my screen here to show you the memo. I just want to bring up the memo from Maine Housing because I didn't think to send it to you again yesterday. This was the question about from Representative Javner about the types of housing available, housing assistance available through Maine Housing, and they said that all of their housing assistance comes from federal funds, and state rental assistance might come from general assistance or other DHHS programs. Talked about the pilot project, and the point of our proposed amendment is simply to say that if a recovery residence tenant had a Section 8 voucher, we would not consider the recovery residence's certification status a factor in providing that rental assistance. Section 8 vouchers require that units meet certain safety and habitability standards, but certification and of a facility in its program would not be a factor. And that's why the sponsor came in and asked for that amendment out of the gate. And then Representative Craven had asked about how programs qualified for a Maine Housing Recovery Residence Pilot Program. And he also sent some information about that and the selection criteria for those that are in the program.
Very good. Does the committee have any questions based on Anna's presentation? I don't see any. I see we are joined by the bill sponsor. Welcome, Representative Fecto. Any comments or questions or considerations based on what Anna has just said? We're not hearing you, Representative Fecto, if you're speaking. Not anything.
Hello, can you hear me now?
Now we can, yes.
Wonderful. So I thought it was a very fair analysis to up to and including the proposed amendment after speaking with Maine Housing. This bill essentially has two functions. One, to make sure that our state dollars are going to certified places that are using really good science-based, nationally backed, research-based approaches to recovery. I think we all here deeply care about recovery. We may maybe disagree at a few different points, but I know everyone on the committee super duper cares about recovery. I'd really like to point the committee to Mr. Brandon Toby's testimony. I thought was the most effective on the second function of the bill, understanding that recovery residences have costs beyond mortgage divided by number of beds. And he laid it out quite realistically to show the drug tests, insurance, internet, electricity, all of those additional costs in order to, just keep the lights on at his recovery residence. And the fact that they felt that they were not being treated fairly when those people were looking for GA. They could get into hotels super easy, but they could not get equal access or fair access to recovery. And so I leave that up. I thought it was a super fair analysis. I'd love to answer more questions. I know I spoke with you, Mr. Chair. I really appreciate you taking the time to answer a few questions, and I'd be open to really anything else. I do think that we could roll this out and basically have this up until, so the implementation of certification could be up until the end of this year. And MAR has agreed to basically present a report to the committee next year in the second regular session, if that's something that this committee wanted, to show you how this rollout has gone and how successful they've been.
So are there questions for Anna or Representative Fecto related to this bill? So, yes, Representative Craven?
Thank you, Mr. Chair. I just wonder what the advantage is for houses not to certify themselves.
So do you want to, does anybody want to speak to what the advantages might be? Is there much cost associated with the process? Is there much detail, and what's the hassle factor? Yes, Representative Zager.
Thank you, Mr. Chair. I'm wondering if we might think Allison Webb, who's the board chair of MAR, is one of the attendees. She may be able to provide light, or shed some light on that.
She'll be joining us shortly. So Representative Fecto, I understand this in part, or at least the first portion is focused on certification to be somewhat of an incentive to get more of the homes that are out there that are not currently certified into the certified category. Do I interpret that right? Okay. All right.
That's correct, Mr. Chair.
Thank you. Welcome, Allison Webb.
Thank you. Thank you for having me. So the question was, why would houses choose not to be certified? Is that what I understood?
One of
Okay.
the questions, yes. Yep.
Sure. So, there's a cost involved, but it, in our minds anyway, is nominal. It's based on a flat fee plus number of beds. And I could get you that exact amount, but I don't have it off the top of my head. And I believe perhaps Ron Springle is on this call, and he may also have that information. So there's a cost involved. There's paperwork involved. We have 2 staff members who walk a house through the paperwork. So I think that actually is not an honest barrier. Frankly, some houses just don't want to be certified. They may not meet certification standards. They may know that they won't meet them, and so they choose not to. They prefer to fly under the radar. I don't have any other answers than that. It's really not a high bar in terms of the so-called hassle factor, which I appreciate. So I don't have another answer than that.
Okay. Dr. Springle, welcome.
Yes, thank you. Thank you, Senator Claxton. So the fees to join MAR are nominal, as our board chairman, Allison Webb, indicated. The annual cost to join MAR is $250 a year, plus $1 a bed. The $1 a bed actually goes to the National Alliance, our parent. If you have more than one recovery house, there's an additional $50 annual assessment. So the fees only really run a few $100s per year. And for that, not only do they get inspections and support and training, but also the imprimatur of having gone to the trouble of being inspected and complying with the national standard. We have about 70 houses now in our state that don't choose to do that yet. Very independent-minded operators, don't want people maybe walking around looking at their operation. Some receive state funding and some don't, but you could probably get a dozen different reasons why they haven't sought certification yet.
Okay. And I guess the risk of pursuing certification as the trigger for general assistance dollars is that some of the homes don't or can't or won't comply, and we lose some capacity in a system where we can't afford really to lose capacity. So that's a question that I wanted to at least float and see what people thought about that. I totally understand the want to get to certification or the goal of certification, but I would hate at a time when things are going south to, in some ways, to lose beds and that are partially supported by GA dollars. Representative Stover?
I'm just wondering, given that, Senator, did Allison or Dr. Springle have, do you have any information that would indicate that we'd lose any of these 70 if they were required to apply to be a member? Have they said that, or do we have anything to base that on?
I have not heard that. I don't know if you have, Ron. I will add that, when we certify a residence, we don't just show up one day and check things out and stamp it yes or no. We spend a fair amount of time with the houses. And so those houses that might feel like they're not ready, we can certainly work with them. We do trainings, we can help them with different procedures and policies. We have stuff written up that they could use as their models. So we can help them. We can help them become certified. I have not heard of anybody saying, if I have to be certified, I'm out of business. Ron, have you heard anything like that?
No, I honestly believe that we will not see any drop in capacity if this bill 964 passes. It'll be from the very beginning, working with the governor's office and Gordon Smith, we agreed to in the carrot and the stick approach, to use the carrot, and that's what this still is, to give them incentive. We don't have statistics on how many of the non-certified houses do accept GA, and so that would be good to know. We just, because they're not licensed or certified or in any other way have any obligation to be in communication with us. Even though we sent out a survey about 6 months ago asking that, we got very poor response. So even our efforts to figure out that kind of information just haven't been successful. I think we have to look at recovery houses as profit-making enterprises, and if certification is the requirement, again at low cost, to be able to continue to receive general assistance, if that is in your profit equation, they'll become certified, and probably without too much argument.
Senator Moore, you had your hand up.
Thank you, Senator Claxton. I appreciate that. I guess I'm trying to understand, when I was reading the analysis, the department currently contracts with Maine Housing to provide operating subsidies to certified recovery residents, and only the MARA certified residents are eligible for funding. So all 51 of those that are certified, are they eligible for subsidies from Maine Housing? Is that what we're saying?
No, that's not quite true.
Okay.
So not only does a MAR certified house have to be certified, they also have to allow persons who use medications for opioid use disorder, or we call that MAT. If you're a certified resident but do not allow people to be present in your house for good reasons on MAT, then you're not eligible for the state subsidy. So right now, of the 50, we now have 53 houses as of today. The number changes all the time. 39 of those allow for MAT, so they're technically eligible for the pilot program with Maine Housing. So I believe they have 16 or 17. The Wabanaki House is going to be soon among that number. That would be 17 receiving the Maine Housing operating subsidies, but the majority don't.
Okay. Does that answer your question, Senator?
It does. To me, I think that would almost be an incentive, but if they have
Yep.
their reasons for not allowing MAT, I can understand that as well.
Right.
Representative Craven.
Thank you, Mr. Chair. I guess I just wanted to say that for people, number one, who are accepting public dollars should be certified or have some kind of standards, and also providing such a sensitive service that I would be totally in favor of having some kind of oversight. Thank you.
Very good. Thank you. Any other comments? Let's stick with the issue of certification. Any other comments, questions, concerns related to that? Okay. The other portion of the bill was the how to take care of the costs of running these things and how the department allocates monies, contracts for GA, and then also getting some consistency of GA funding across multiple municipalities because of the known variability. Any questions or concerns or thoughts about that? So I Yes, Anna.
I don't actually see, and Molly could correct me if I'm wrong, but I don't see how the language in this bill gets at the issue that the sponsor mentioned about there being additional costs to a recovery residence. I only see the way this is drafted is that general assistance municipalities can't turn away a person who's living in a recovery residence, and that the maximum levels for housing assistance for the cost of recovery residents apply in the same manner as maximum levels of housing assistance for anybody else. And, they're never enough, just so you know, the amount that you get from general assistance is never enough for anything. I mean, it's a small amount of aid, but I just wanted to mention that I don't see how this bill fixes that problem as it's written.
Is that something you want to address, Representative Fecto?
Absolutely. I mean, when you look at what GA would allow someone to stay in a hotel at $50 a day, that would be, $1,500 a month paid to that hotel that has 0 recovery resident services. And the way they're making recovery residences open up their books and crunch the numbers, the recovery residence operators are unable to afford to take the person on in order to give them the recovery. The amount of money is too little in order to do that based on what they're seeing. Essentially, it's mortgage divided by number of beds, as you saw in Mr. Brandon Toby's testimony. He was saying that he barely operates enough at 500, and they were only offering 300. So he quite literally is taking these people on and then has to jump through hoops through charities or his own pocket, his own profits in order to do it. So I think there is a, when you're paying $1,500 to a hotel with 0 services or $300 to a place with services, there is inequity happening right now. And so this bill would just ensure that they're basically using a formula that's consistent with those rates that they're paying to house the person in a lodge.
And what I'm hearing Anna say is that the bill currently doesn't include language that explains the intent to broaden what's compensated for in general assistance dollars. Is that what am I summarizing that, Anna? Yeah, okay. So that's one question. So you need some language to say the following should be figured in the cost of general assistance payments per person per day would include mortgage, and then a number of other items, I should think, to get to what you want, Representative Fecto. Dr. Springle?
I know this is a sticky problem, given the memo that Sarah Russell wrote January 31, 2020, devising this formula. What we're really looking for is advertised rate. So my understanding is that the GA will negotiate with a hotel or other lodging for a percentage of their advertised rate. And we think that the cost of recovery housing being usually about $150 a week, $600 a month, that a reasonable percentage of their advertised rate would help to solve this problem. I'm thinking the number roughly 80% of advertised rate. That way it wouldn't be the same in every recovery house, but it would be the same within the organizations. So Fresh Start Sober Living, for example, Bangor and Brewer, they have 7 recovery houses. They charge $600 a month. Bangor gives them about $300. Brewer gives them nothing. If you're in a certified house in Brewer, you cannot receive a penny because you're in a recovery house. That's the municipality of Brewer. So that's what we're trying to level the playing field, and also then to combat the problem that Representative Fecto has pointed out with Mr. Toby in the Augusta Fresh Out sober living establishment. But a percentage of advertised rate seems to be an easy way to avoid doing calculations and to put this more on par with the other housing options for general assistance.
And the rate you're talking about is a local low-end hotel rate, or the rate that's negotiated?
It would be the advertised rate of the recovery residence.
Okay, okay. Okay, Representative Fecto?
Thank you, Mr. Chair. In lines 21 through 24 of my bill, in section 3 of my bill, I'm just wondering what Ms. Broom thinks that means then. Is that just the maximum rate, but they would still establish the formula differently? I guess I'm having an issue just understanding.
Well, that's because it's horrible to try and understand the housing assistance and the general assistance law, Representative. That's why. I suspect that the department can probably answer the question better than I can, but I just read that as the same manner as maximum levels of housing assistance, because there are maximum housing assistance levels in the statute already.
Mhm.
And that's how I read it to apply here as well. I can't speak to how they calculate a person in an apartment with roommates when they're doing general assistance. The department would have to answer that question, because I think that's more the issue here, is how, and Molly, feel free to shake your head at me if I'm going completely off the rails here, but I think what the problem that you're identifying is that a recovery residence, which has a number of people living in it, is not exactly equivalent in terms of what it costs to run as a person living in an apartment with a bunch of roommates, where there isn't those extra things that you're talking about. And I don't know how, when a municipality is determining what the housing cost for a person who's living in a recovery residence versus a roommate, I don't know whether I'm assuming they would be the same, and that's the problem I think that you're identifying. But in terms of the maximum housing, that's how I read that section, is that if you bump up against the maximum housing wherever you live, you bump up against the maximum housing. So now I'm at the extent of what I understand and have to move to the department to go further.
Is that something you can help with, Molly?
Well, Sarah Denson, who's our program manager for general assistance, is in the attendee list and might be able to shed some light.
She's coming in. Welcome, Sarah Denson.
Hi.
We can hear you.
Hold on just a second.
Now we can see you.
Okay, good. I kind of blanked out for a second and popped back in, so I wasn't quite sure.
That's the wormhole.
Yeah, thanks for having me. I'm happy to answer any questions. I was a GA administrator for many years, and I've been the program manager, so I've got a good perspective, I like to think.
Okay. So the current conversation is about how to get to a rate for recovery residences that's generous enough to reflect their costs more than just mortgage. And one of the proposals is to do it as a percentage of the advertised room rate. The problem with that might be, why don't we go to $1,000 a month as the advertised rate? I don't know what the constraints on that are. So we're trying to figure out some way, or the discussion is about some way to figure out how to get more general assistance dollars, because it's cheaper to have somebody in our residency recovery center than it is in a hotel room. I think that's the argument.
Okay. So the general assistance application includes a budget, and the budget is calculated based on someone's income and what their expenses are, and it's weighed against what the maximum allowances are for their household size based on where they live in the state. Every year, approximately August to September, the Maine Municipal Association reviews all of the HUD calculations at the federal level to determine what the rents are, what the average rents are in each county and metropolitan area in the state of Maine. And then we take those numbers and make adjustments to the previous year's numbers. They are approved by the Maine Welfare Directors Association Board, and they go by me, and then they're approved by me as well. In most cases, those numbers only change a few dollars. Sometimes you'll see a bit more, but they are looked at annually, and it's based on HUD figures. So those amounts for housing are set rates based on how many bedrooms a unit has. So when we're looking at the cost of housing, the allowed amount for housing, we're looking for it to fall within that guideline of what the maximum is for that specific location. So just to give you an example, in Kennebec County, a 1-bedroom unit is $724 a month. It does not matter if there is 1 adult living in a 1-bedroom unit or 2 adults living in a 1-bedroom unit. The 1-bedroom rate is $724. If you had a 4-bedroom rate in Kennebec County for a heated unit, it's $1,268. An issue that we've run into with recovery residences and general assistance is that many of the recovery residences that come across GA or that try to work with GA have a home or a building with a limited number of bedrooms, let's say 4 or 5 or even 3 sometimes. It's a limited number. However, maybe there's 4 bedrooms, but they've got people double bunked, so to speak. So people are sharing a bedroom. The recovery residence owner, operator, manager requests the full 1-bedroom rate per person. So for a 4-bedroom, for let's say we have a family of, you could have a family of 8 in a 4-bedroom, GA would pay $1,268. The recovery residence is asking for 8 individuals in the recovery residence over $5,000. It's ends up being, in this example, it would be $5,792 in a 30-day period for those 8 people. So you can see how that's quite different. And we do take into consideration things like electricity, and we can adjust the rates for that amount. There are certain things that we don't consider a basic necessity by GA law, such as internet. And so I did take quite a bit of time reviewing the definitions and different laws regarding pro rata share, because that's something that we do when we have a household. Let's say, for instance, you have 2 adult men who are roommates and they do not have commingling funds. They don't share anything. They each pay their portion of a rental. So in that case, we would take the maximum allowance and we would divide it by 2. If the rent is, say, $800, they would each need $400. That falls within the guidelines. So following that kind of train of thought, we are looking at recovery residences currently, and this is what the guidance referred to that was issued last year. We're saying, okay, show us how much it costs to run this recovery residence. Taxes, mortgage, water, sewer, electricity, all of these things without the internet, because like I said, unfortunately, we can't include that. And then we're determining what the pro rata share is. And so I do understand that that has, it's been something that the owner or operator has not been really enthusiastic about. But in terms of general assistance, it seemed the most fair way to meet them halfway with what they were asking for expenses and for a payment versus what we would otherwise do, which would be, you have a 4-bedroom building, we're not going to pay you more than $1,200 in a month. Hopefully that answers your question. Sorry, I know it's a lot.
Way into the weeds.
Yeah.
But thank you for your expertise and laying that out. I think I certainly understand a bit better than I did. Representative Zager?
Thank you, Mr. Chair. And I appreciate that, Ms. Denson, for elaborating on that. Representative Fecto has contrasted what is being paid or might be paid to recovery residences with what GA would pay for a hotel or motel room. And so as I'm thinking this through, like if we had, I don't want to like run through the numbers. I mean, I can run through my thinking if anyone wants, but if we just imagine what a GA might spend for 8 people to stay in a hotel room, that would be like $12,000 for a month. But what I'm hearing, what Ms. Denson just said, is that would be $1,200, $1,268. So there's an order of magnitude difference, and I guess this committee is trying to figure out where along that order of magnitude difference it's the right value, because one seems to not answer be sufficient for the true costs and the services that recovery residences are providing. It's not just a place to lay your head, but it's services, and there's the whole milieu and et cetera. So it's somewhere between $1,200 and $12,000 seems to be what we have to decide on.
Any thoughts about that? It's an order of magnitude. Did you want to say something, Ms. Denson? Go, jump right in.
Yes, thank you. I just wanted to note that what we issue for payments or for assistance for hotels are considered temporary lodging. They're not considered a permanent residence. In most cases, when we're assisting someone in a recovery residence, they're there for an extended period of time. They're there for, I don't know the statistics to say an average duration, perhaps Mar would know more, but in my experience, they're there for 3 months or longer, sometimes quite a bit longer. And so it's considered more of a permanent residence, whereas a hotel is temporary lodging. In most cases, a hotel is only used until the following business day. Usually we're looking at less than a week, maybe 1 or 2 nights at most, in order to find that person or secure that person with some permanent housing or permanent residence. It is true we've had people in hotels for much longer duration this past year. As you know, we're in a pandemic. We also have an executive order in place from Governor Mills that requires us to treat all applications as emergencies. And so there are cases where we've had to exceed our normal maximums in order to provide a safe living location for people during the pandemic. And so that is true. People have been there longer, but in most cases it is just temporary. And so it's not quite 30 days of hotel stay every month.
Okay. So just to leave this topic of cost reimbursement for a second, the other part of the bill that isn't specifically pulled out, but it also represents as part of this conversation is the GA denial. And this bill would make it illegal to not give somebody GA just because they were living in a residency recovery recovery center. How do we enforce that? How do we track that Bangor pays X number of dollars and Brewer doesn't pay anything, or whatever the example was. How do we know that? How do we fix that?
Unfortunately, at this time, we don't have a tracking system to determine what the numbers are for recovery residents individuals.
Yeah.
I certainly could put out some feelers and request data from the communities, and I'm sure that they could provide that for me. What we really rely on is that applicants and other communities report any abnormalities or any issues that they might come in contact with. We at the department, we have 2 field examiners and myself, and we investigate any claims or reports where people feel that they're being wrongfully denied, that an incorrect decision was made, or that they were illegally denied the right to apply. And we look into those and we take those very seriously. We conduct audits as well. And so we would have a lot of questions about that. It always concerns me if I hear something kind of third hand, because that's something that I want to then investigate so that we can take care of that problem.
And can you speak at all to the volume of those complaints you've had at any given time?
I have had a lot of questions from the municipalities with concerns. I know there was a question earlier about what the reason might be for someone to not get certified. I think that there can be concerns about individuals opening recovery residences, and do they have good intentions? Are they trying to house too many individuals in this small space? So I know that the municipalities have had questions in regards to how to handle those cases and applications. To the best of my knowledge, I do not know anyone that has been, I haven't heard of any stories where somebody was denied simply because they live in a recovery residence.
And we have, so that's a concern that I just wanted to bring up anyway. So at this point, it sounds like we've thoroughly discussed certified or not certified. And my guess is, well, I won't guess, that there aren't a lot of questions left related to that piece. And the question is, and I assume that the department would then have to write rules for this bill that would say how soon this would take place. We can't overnight. So this is a question to Molly. We can't overnight say, if you're not certified, we're not giving you any GA money. So there must be some sort of phase in or process that the department will have to write rules for.
Yes, I imagine that if and the folks from MAR can chime in on this as well, but I imagine if that became a requirement, we would have to make that amendment in our rules, and then there would likely be a period of time needed for those folks, those recovery residences, to seek and receive certification. And I don't know how long that process takes, or what the capacity is to do a number of those, so would defer to Mara on that.
Well, the bill also doesn't specify a timeline, so theoretically you could do it over the next year or so, based on what I read anyway. Dr. Sprinkle?
Yes, thank you, Senator Claxton. New Hampshire, the New Hampshire group that is analogous to MAR, last summer, not through their efforts, but through a sort of a back door, passed a rule that required recovery residents to be certified to receive these public funds. They saw a 70% increase in the number of recovery houses that were applying for membership in the NAR affiliate in New Hampshire. We would expect something similar. We have limited staffing capabilities, so we certainly think that at least a 12-month type of period would allow us sufficient time to process people in a timely way. I know that Representative Fecto discussed that, so let me leave that up to him in terms of delayed implementation.
Okay. And then that I come back to the other question about what happens on 1 year plus 1 day when it goes into effect and X number of houses aren't certified. Does that mean that any GA monies flowing at that point that are turned off
Well,
for the non-certified houses?
yeah, I believe that would be the intent of the rule or the effect of it.
So they would have had a year's notice.
Yes, and ample opportunity to receive certification. It's a 30 to 60 day process to become certified. It's not that onerous.
Okay. And Senator Baldacci?
Thank you, Mr. Chairman. I was going to ask, I mean, we could put an amendment at the very beginning saying, that says commencing July 1st, 2022. So that gives a year for the rules, gives a year for people to get certification done. I think certification is important. As has been testified here, it's kind of a minimal standard. And, but it ensures that the public's money is going to at least people, entities that have met minimum licensing standards, which I think is important. So with that amendment and the others that have been discussed, I would make a motion. If I would be happy to make a motion at the point the chair is ready to entertain motions.
Thank you, sir. I still think there's some work to be done on the cost end of things that I don't think we've resolved, to at least to my understanding. Representative Perry?
So the only question I had, if we move along with this, is that I don't want somebody who happens to be in a house that has been covered by GA for a while, but the house is not MAR certified, that he suddenly has lost, he or she, his GA. So there's got to be a way to sort of make sure that the people who are already on GA in that transition are not suddenly without help.
So you want to grandfather people who are currently collecting GA in non-certified houses as of June 30th? Is that what I'm hearing?
I think that's what I'm hearing. That's what I'm saying.
That's what you're
I
thinking.
just don't want somebody left, in the lurch.
I mean, the counter argument is they would have had a year's notice to find a place that was certified or work to help the certification process. Yes, Representative Meyer.
Thank you, Mr. Chair. There's been a lot of discussion here, so I'm just trying to get things straight in my mind. Are we using this bill as a vehicle to require recovery residences to become certified?
That's what the intent of the bill is. To get GA dollars, as I understand.
To get GA dollars.
Yes.
But are we using it to require recovery residences to become certified? Period.
I didn't read it that way, but we can ask Anna. This isn't a blanket requirement for all recovery residences to become certified, right?
It depends how you write it. Right now, it is GA and main housing. For those with
some of the
federal
discussion is circling around that, requiring, which was not, if I recall, part of the public hearing.
Well, it says must be certified.
In order
Yeah.
to receive, yeah.
Right. Should be, I mean, yes. Plus it also specific about municipalities not denying things.
No.
It actually doesn't say, you're right, it doesn't say in here that, well, I don't know what section 2005, subsection 22 is. So it's contracts for recovery services, recovery residents or services related to the recovery residents. So that's are these contracts when people who go into recovery centers? This isn't a contract, is it? The contract is with the recovery center and main housing or whatever. Representative Fecto, can you help us out here?
I'd love to, but my internet connection is unstable. I'm trying to pull the page up for you.
Yes, while you're doing that, do we want to go to Dr. Springle?
Yes, thanks, Senator Claxton. I wanted to respond to Representative Perry's concern that someone might be dropped from GA a year from now or a year from July 2021. The average length of stay in a MAR certified house in Maine is approximately 6 months, a little bit less. We have very few people that actually stay for that long. And the idea behind GA is to be a temporary hand up. It's not for months and months and months of housing support. It's really, most people, when they get to the place where they're just entering in recovery residence, they have no money, no job, no recovery capital or very little. The GA is a hand up for the first month or 2 or 3 until they become employable and get employment and support themselves and pay their own way. So with the year's notice, I just couldn't conceive of anyone that would be kicked off of the GA support a year from that date.
Yeah, the summary reads differently than the body of the text, the way I read it, having spent some more time with it. Representative Fecto.
Thank you, Mr. Chair. Section 20,005, subsection 22 discusses certification of recovery residences. And so that's not a contract. It just discusses the established by rule criteria certification of recovery residences. I shared the link in the chat. And so it's the certification of those recovery residences that's in statute that I believe Ms. Brooms discussed earlier.
So we're in 20,005 subsection 22. Okay. So, but this already exists, so it's not as if we're adding to it.
I think what's not clear to me actually is what the subsection 1 of the bill does, and maybe I'm sorry to throw this at you, Molly, but I don't really know. So it says recovery residents must be certified to receive, and then subsection 1 is contracts, any department contract for a recovery resident or services related to the recovery residents. I don't know whether that's a thing or not. And then subsection 2 is the part we've been talking about with the housing assistance voucher, but I don't actually know if there are services related to a recovery residence that come from the department that would be impacted by this or not. I'm sorry, I should have realized that ahead of time, but I don't know the answer.
Molly, are there contracts out there that we should be careful with?
I don't know. I can see if I can find that out. I don't know if Dr. Springle or Allison may know if there are Office of Behavioral Health contracts that go for some or all of the functions of recovery residences, but I'll see if I can find the answer out.
Okay.
The only contract I'm aware of is between the Office of Behavioral Health and Maine Housing for the operating subsidy program. I'm not aware of any others.
Yeah.
Okay. All right. So does that answer your question, Representative Meyer, about mandatory certification? Because that's not really what it says. It says certification is required to get GA dollars. Did that answer that question? Representative Perry.
Yeah. I just lost track of what I was going to ask.
Well, we'll be here for a while, so when it comes back.
Oh, I remember.
Okay.
I'm sorry. I guess in terms of calculating GA, and that's the thing I'm really sort of trying to figure out, is even though it's a residence, essentially you're renting a room. So are you looking at with GA at as a, I don't know if she's still here. Oh, yes, you are. There you are. But, you know, I've rented a room in a home, but my room is my place. Not that the home is there, but I'm renting the room. In a recovery residence, and I guess that's a question, are they essentially renting a room?
Ms. Denson?
Well, I'm not actually, sorry. Are they renting just the room? I don't know if perhaps someone from MAR might be more qualified to answer the question about what it is that the agreement is. It's my understanding that they are renting a room. However, they're sharing bathrooms, they're sharing kitchenettes, they have shared living space other than just the room.
And they're paying for access to the support services related to the SUD. Yeah, Ms. Webb, Allison Webb.
Sure. Can you hear me?
We can.
Okay, thanks. I feel like we might be getting into the weeds when we say, are they renting a room? Well, they're renting a space for sure, but the services that they receive, I wouldn't even call them services. I would call it the living environment that they gain, is just not like renting a room. So technically, yeah, they're renting a room and a cupboard in the kitchen with some living rules, but that would not be how anybody that I know would talk about recovery housing. So they are paying for living, a family environment, a structured environment, a drug-free environment, access to possible employment, volunteer opportunities, all those other things that go along with being in the house. So yeah, they're renting a room. That's really not what's happening. Does that help?
I think so. I was just trying to figure out how to define this for GA to make it more complicated.
I know.
Representative Fecto?
Thank you, Mr. Chair. I think after all this discussion, one, I learned that I never want to work in the GA office because it's way too confusing for me. And two, that Dr. Springle's original discussion of an amendment of 80% on the single room rate might be appropriate here, because when we discussed, when Ms. Denson discussed Augusta was $724, I believe, 80% of that would be $579. And that's right within the ballpark of the operating costs that Mr. Toby needed. And it might be within the operating costs locally that many of these other places need, understanding that they're accessing and paying for other services.
Yes, Representative Zager.
Thank you, Mr. Chair. There might be a path to go down, but that 80%, that was 80% of the
advertised room rate.
Right, like one is from the advertised rate, which is simply what a proprietor chooses to offer for. The other was based on HUD data that went through the Maine Welfare Board, et cetera. So they're really two different things, but the idea of using some sort of that benchmark, maybe that federally rooted benchmark is the way to go, and then we pick a percentage of that, as Representative Fecto said.
That sounds like a yes. Representative Fecto.
Thank you, Mr. Chair. I believe the 724 was the HUD rate, because if someone's renting places out for $724 in Augusta, I gotta give my number.
Okay, so how does that sound to the folks, to Ms. Webb and Dr. Springle? How would that work on your end?
Could you just clarify? I just want to be like crystal clear about what we're talking about. I just want to be sure.
The current question is if we used 80% of the established room rate using HUD numbers.
So the HUD rental rate for that geographical
month.
area, 80% of that. Okay. Okay.
Yes, Dr. Springle?
Yeah, I think that would simplify matters quite a bit. Now, bear in mind that recovery residences vary in their advertised costs, but the higher programs, for example, when Dr. Zager was visiting in his district this past week, some of those houses are several $1,000s a month. They're not the houses that we're talking about. Those are usually paid for by wealthy families and not people that are indigent. So when we talk about low barrier, which is the ones we're talking about now that receive GA, they go from about $600 to about $800, which fits well within the HUD guidelines. I received an education from Steve McDermott at Maine Housing, who operates the MAR Maine Housing Operating Subsidy Program, who schooled me on the HUD rates and how they vary from town to town, but they don't vary that much. I mean, and I think that Sarah could, Sarah's still on the line, Ms. Denson, could give us a little more information, but it would certainly put us in more of the ballpark and be much closer to what I think we would all agree would be a reasonable rate.
Ms. Denson, do you want to respond to that? The idea of 80% of the HUD number?
I'd love to. I think that having some kind of an established rate would be appropriate. I think it would be really helpful to have a set number or set numbers for everyone so that everybody knows what the expectation is, and certainly would allow for things to be done without the need to provide all the financial documents for the recovery residence owner, manager, operator. I question the 80% amount, and the only reason with my hesitation is that we do find, and perhaps this problem would be solved by virtue of being certified, but we have found situations in GA where the operator of the recovery residence is really renting to multiple individuals who are sharing a room. And so it does concern me that you could have $1,500 for 3 different people, or $1,600, or give or take, for 1 bedroom, who would be in 1 bedroom. And so perhaps that's more to do with what the guidelines are for certification and how many people are allowed in a room and whatnot. But I do have hesitation and concerns about that.
Molly, do you have any feedback at this point or any thoughts?
I appreciate that. I think Sarah is right. I think it's important to make sure we're clear on whether we're paying a per room rate or a per person rate, and what that 80% would be, whether it would be for a room or for, regardless of the number of people in that room, or for a per person. And I think, there are a bunch of questions that brings up that is more appropriate for the certification process. And, as far as, actually, I'll leave it there.
Okay.
Thanks.
Representative Fecto, how would you feel about a directive to the department to establish a methodology for payment that was based on the HUD numbers, but the percentage in per room versus per person was established in rulemaking?
Thank you, Mr. Chair. I really like per room. That's what I like, especially when we're talking about the NAR standards, because there's lots of dignity built into the standards, as in certain amount of people per room, and now we have there's only 6 people per bathroom, so we're not stacking people with the NAR standards. I think it would be appropriate to have the department look at this further, but the per person rate is just not enough for these people to go get the services they need.
Well, if it was per person and it was 80% of as if you're renting your own room, it'd be a very different number. But yeah, no, I understand what you're saying. But it still leaves unresolved the issue whether it's 80 or 62 or 75%. And I don't really feel like this is a committee to make that determination based on our relative inexperience with these issues. I feel much better. Yes, Representative Vecto.
I think I would feel definitely more comfortable if MAR was invited. And so they could, they could really have strong input on what's needed because they understand the costs. I understand that we're getting into a point where maybe we don't have the brains to figure this out on a Zoom call right now, which I super appreciate, but I would want MAR super involved in these conversations.
So Molly, to you and the department, if they're going to have to do some rate setting rules based on per person less likely, but per room more likely, and then as a percentage of HUD dollars, can we assure that MAR is involved in the conversation about setting that formula up as a invested stakeholder? How do we go about it?
Sure, and I welcome Sarah to comment on this because this would be a different rate setting than the rate setting we're normally talking about here, which is main care. This would be general assistance rules, and but at the very baseline, every rule promulgation that we do is required to follow the Administrative Procedures Act, which includes stakeholder engagement. But I expect that Sarah would welcome feedback from MAR prior to the drafting of that rule.
Would you be okay with that, Ms. Denson?
Absolutely.
That's the right answer. Thank you very much. All right. Yes, Representative Perry.
I'd like to make a motion.
Okay.
Ought to pass for GA in a year that in order to be accepted for GA, you need to be in a MAR or a certified residence. And also that the department work to develop rules around what GA payment would be in terms of payment for the recovery houses.
Is there a second for that motion? There's a second. Thank you, Representative Zager. So what additional clarification do you need, Anna, before we go any further?
I just want to make sure that that's the whole amendment. In other words, are you replacing the original bill and those are the two things that it would do? So the first one would largely look like section 1 of the bill, but with a date in it. And it sounds like it's GA specifically, not main housing or any other contract language, but GA specifically. And then it sounded to me from what Representative Perry said was that then you would have GA the department making rules on GA to establish appropriate rates for reimbursement. Yeah,
Yep.
Okay, as long as that's it, that's what I wanted. That's what I wanted to know.
Yes, Representative Zager.
Thank you, Mr. Chair. And also just on the drafting question, like lines 24 through 27, did you mean to include that as well, Anna? Is that what you had in mind?
Yes, I think that's part of section 1. You're right. My question was actually about the about lines 17 and 18. That's what I was asking about, because I heard no mention of that. That's the part about not denying general assistance based on a person residing in a recovery residence. That's what I didn't hear in the motion.
Then I was going to leave it in there. Representative Fecto.
So I just want to make sure I'm having a hard time picking this up. So we're essentially talking about this delayed implementation on the section 20,057 would be delayed for 1 year. So we're talking July 2022. And that section 3 would be reworded to direct the department to come up with appropriate rates and adding in any sort of main housing thing, like to the extent not out of compliance with federal law.
That was one of my questions, because I didn't hear main housing in that motion at all.
And so, yeah, that's what I didn't hear. I didn't hear this, the first sections 1 and 2 of the beginning portion. I didn't hear that. I just heard the discussion around GA. So I just wanted to make sure I understood the motion.
And you would like to keep the portion where it says you can't be denied GA if you're in a residency, recovery residence or recovery residence for now. Yeah, okay. So yes, I think it'd be fair to include that language about not in conflict with federal law where it fits.
So you do want main housing in there? That's the question that
Oh,
I'm
is that
asking
why they're
you.
involved? Oh, okay. Oh, okay.
The way this is drafted right now, it says any department contract for a recovery residence or services related to a recovery residence, which sounds like it is main housing. And then subsection 2 is general assistance or main state housing. What I only heard in the motion was GA. That's what I'm trying to figure out, is what you actually want in the bill in the end. Whether you want all of this, but with a date. That's what I'm trying to understand. I know what the sponsor wants, not clear to me what the committee put in their motion.
Representative Meyer.
Thank you, Mr. Chair. So I'm going back to lines 24 through 27. So are we saying that a municipality may not provide housing assistance to a person in a recovery residence that has not been certified?
As of a certain date is what I heard.
Yeah, that's.
What date was that?
July 1, 22.
2022.
That's the year.
Okay, so for the next, until that date, if you are seeking recovery in a non-certified recovery residence, you cannot be denied.
Right.
Right. It would need to be completely broken apart the way it's drafted at the moment. Yep. In order to do what you just mentioned. Yes, that's right.
Because that also ties to the very first sentence where it says may not deny GA to a person for the fact that they're residing in a recovery residency. So the first and last sentences are hooked together, but they're not close together. Does that answer your question, Representative Meyer?
It does. I still have concerns, though. You know, we all agree that there should be no wrong door for those seeking recovery. So I just get a little bit concerned that we've got for those recovery that we're telling recovery residences, you must be certified by the state
to get GA dollars
in order for your residents, those individuals seeking recovery there, to qualify for GA dollars.
Right.
So, you know, at some point in time, there are going to be wrong doors.
Yep.
And that concerns me.
And that's why I raised the issue of the grandfathering. Do we want to grandfather people who are currently in a recovery residency as of June 30th until they're no longer there? So if they showed up on the 15th and they're going to be there for 3 months, do we allow them access to GA for the next 2.5 months? Molly?
Thank you. Representative Meyer really expressed what I wanted to say, but just to put a finer point on what this amendment would do, if in August of 2022, someone who needed general assistance was seeking to live in a recovery residence that was not certified, they would be denied general assistance. That after that year.
Yes. So the argument was being they shouldn't have gone into a non-certified facility. They would we'd have to figure out some way to get them to a certified facility and hope there's enough beds. Yes, Ms. Denson. Where'd you go?
I just wanted to throw out that a lot of times in general assistance, we look at whether someone's making a good faith effort, or if they have, I can't think of the phrase at the moment, but it's almost like probable cause. Like if they've put forth some kind of effort, or they have shown that they're working on something, then we might continue to allow, and we kind of give them a good grace period, so to speak. And so that's always an option as well. If there's individuals who are in a recovery residence and it's not certified, perhaps we consider, whether there's a grace period, or whether they have the option to continue to receive payments because they've shown to us that they're continuing to search for a place that is certified, or something to that effect. Is just an idea.
Thank you. Representative Craven?
Thank you, Mr. Chair. I guess that I feel more and more concerned about standards of safety and standards of, is somebody pecking for people into a room because they have concerns about them, or because they want to make money off the situation? It's not something that I thought about before, but listen to the conversation today. Now I'm really concerned.
So does that mean that you're in favor of the certification pathway as for a year from now?
Yes, I am.
Representative Perry?
I just wanted to thank Ms. Denson regarding the ability for somebody who ends up in a non-certified home to give them the help that they need to move forward to what might be a certified home. I hate the thought of cutting somebody off when they're honestly trying. So I think that makes me feel better. Thank you.
Dr. Springle and then Senator Baldacci.
Thank you, Mr. Chairman. I don't want to diminish the concerns that Representative Meyer or others have about discontinuation of GA for someone that's receiving it, or that a door would not be open to them. I think that there is a balance involved in that. We do not know what happens behind the closed doors of the non-certified houses. We don't know if they're putting in 10 people in a basement and separating them by sheets. We hear things. The recovery community is not that small in Maine. We do hear rumors about drug use and things of that nature. We have not yet, hopefully, cross our fingers, seen some of the most egregious types of behaviors in recovery housing, such as patient brokering and trafficking and things of that nature. But we don't want to see those here. Part of the reason that MAR started was to adopt the high ethical standards of the national group. And by going into houses every year or more often, by having ombudsmen present, a program for receiving complaints, grievances from the current residents, we know what's going on in the houses, or we find out quickly. In the non-certified houses, we have no idea what's going on, only by rumor, and then only after the fact. There was a house on Congress Street, non-certified, 3 fatal overdoses in 3 months happened. Now, fortunately, that place has been shut down. That's not happening in certified houses. There's just not that many people receiving GA for months and months and months at a time. If they are, there's something wrong with the program, because the idea is to get someone back on their feet. A year should be plenty of time to get the word out to the non-certified houses. If that's critical to their business plan and to their income stream, they've got plenty of time to apply for certification and attain it.
Senator Baldacci, thank you for that, sir. Senator Baldacci?
Yes, I had my hand up several times. I have several questions. One is, where are we now with any amendments? Because I'm not clear exactly where we are. That's my first question. Can somebody inform me?
So on line 12, related to housing assistance in the Maine State Housing Authority, we will be adding language that would be not in conflict with federal laws. That's one of the amendments. We would be pushing out, we would be establishing a deadline of June 30th for becoming compliant, 2022. And if somebody, and to receive, to take in clients who are dependent upon GA or receiving GA. So as of July 1, though, anybody that got admitted to your recovery residency wouldn't get GA if you were not certified.
Okay, so there's no grandfathering clause.
No.
It's just a clause
I just-
of effective.
Just floating a crazy idea, but no grandfathering.
No. I just want to make sure where we were. So
Sure.
I think the reason I originally had my hand up was because I wanted to address Representative Perry's point on the municipality, the line towards the bottom where it's in section 3E. A municipality may not provide housing assistance to a person in a recovery residence that has not been certified, comma, after having received 30 days of notice. Okay, I think that the only thing that we should do, the only addition I would make, and I throw this out there, is that the town should give them, whoever, 30 days notice, because the individual may or may not know whether it's a recovery certified or not. So I think if we give them 30 days notice, then I think putting in more and more regulations for the town to administer is not going to make sense. I think we give them a notice. And then on the overarching issue, I think that we're doing what we should be doing with this bill, because the state has already set up a structure for licensing. So there's a reason that people get licensed. We don't pay unlicensed doctors. We don't pay unlicensed lawyers. We don't pay people who don't have a license to do certain things. These people are representing to the public that they are a recovery residence, which our state has a licensing structure. So I think I'm all for commencing July 1st to give everybody a year. And I would give people who are on general assistance that they should be given 30 days notice from the town, because they may, when they apply for the assistance and say where they're living, they should get it. So they're not thrown on the street. They should get 30 days notice in order to change the situation. But beyond that, I'm ready to vote in support of the bill.
And the last amendment was to task the department with coming up with a GA payment mechanism for those folks in residency recovery that was based probably on a per room basis and as a percentage of HUD determined annual numbers.
Well, the only thing I would add, having been involved locally with general assistance, is that there is a formula already for housing. So I'm not sure.
That's the one we would use. We're just talking about the GA payment to the
Right,
individual.
but there's a formula that GA uses already for housing. So
And what we're hearing is that it's too small.
Oh, okay. Okay, well, I'm fine with whatever the committee wants on that, but I just wanted to make sure I knew where we were on these amendments. But thank you very much, Mr. Chairman.
Thank you. And I've been, yes, Molly.
Thanks. Senator Baldacci mentioned licensing, and I just want to be really clear with all of the respect to our partners at MAR. It is not a license, it is a certification. And when we talk about licensing at DHHS, that involves a host of enforcement and requirements and all sorts of things that these residences are not subject to based on their certification with MAR. So I just wanted to offer that clarification. Thank you.
Thank you. Representative Zager.
Thank you, Mr. Chair. And I really appreciate everyone's robust discussion here as we dig in here. I'm thinking about what Representative Meyer said about the no wrong door, concern or idea, and wondering if the committee might want to consider some way to make sure that that there are standards. So there's not 3 deaths in 3 months and overdose deaths in 3 months in one facility, et cetera. But that people can who are not going to who might be bewildered by where to even start could have guidance, assistance to maybe find a certified residence or some sort of appeals process if they don't know where to go and they find themselves in a place that is advertising as a recovery residence. They think they're doing the right thing for their wellness and find themselves unable to draw GA. So like I'm wondering if we can simultaneously ensure standards, but also make sure that we're not leaving people out to dry.
And I think that becomes a responsibility of the GA department or program itself in the process of finding, that's the 30 days before discharge from the incarceration. We've got a plan and you're going to a certified house. And this is what that means. If we don't want you going to an uncertified house, because it's now August 1st. So I think that's a GA responsibility. Am I right, Ms. Denson? Okay, so that's within your purview to make sure that the people who are signing up for GA are directed to certified houses. Okay. Molly.
Well, and I welcome Sarah to correct me here, but I just want to be clear. GA does not offer sort of case management services. GA would tell you, yes, you can get reimbursed. We will support you using this house, or no, we will not support you using this house. Right. But as far as a sort of case management navigator service, that is not the role of municipal general assistance.
I appreciate that, but we're also not sending them to a web link to look up where's a certified house and go talk to those people. We might be able to give them some direction. Okay, Representative Meyer.
Thank you, Mr. Chair. I was thinking along the same lines as Ms. Bogart, is that, remembering, knowing that GA is administered at the municipal level, and knowing that for the most part, those administering GA in our cities and towns have a lot on their plate and don't in any way or should not in any way be seen as navigators, case managers, or even understanding the nature of recovery residences. And I'm grateful to Ms. Denson for her expertise and for being here today to help us through this very dense subject matter. But I do also think we need to remember what we are hoisting on our municipal GA administrators here.
Okay. Any other comments? So the motion on the floor is ought to pass as amended and moved and seconded. The amendments we went through are the 4 that we just summarized in the conversation back and forth with Senator Baldacci. Is that enough detail for folks to feel comfortable voting? Representative Meyer.
It's late in the day, but I would ask for a 5-minute corner caucus, please.
Okay. So if you will indulge us, Representative Griffin, we'll be back at 3:50. I know you guys did much better than we did in terms of your time.
Just saying, I know.
No, I know. All right. So at this point, we're reconvening. We're restarting the conversation or continuing the conversation. The motion on the floor is ought to pass as amended. The amendments, Anna, correct me when I'm wrong, that will add verbiage to make sure we don't break any federal laws, not in conflict with federal laws as relates to main housing. We're going to require that homes pursue certification by the end of 6/30/22 if they want their occupants to be continuing to receive general assistance dollars. That affirmative from some dog. We also have general assistance payments cannot be denied simply because you're in a recovery residence. And the fourth, as I understand it, is that if you are in a residence where you are vulnerable, where you are going to lose your GA benefits because it's not certified, you get 30 days notice.
I also thought there was a rate setting piece in there. The
And
part
the
about, yeah,
charge to the department to
Yeah.
come up with a plan to figure out how to more appropriately reimburse recovery residences or to,
right.
yeah. to
Right, the
pay-
per room percentage of HUD thing. So just to get back to the 30 days notice, because that wasn't originally in your thing. So my understanding from GA law is that a person who is on GA has to be, their eligibility is determined every 30 days.
Yeah.
So you're asking to require the department, I mean, the municipality to tell somebody who is getting approved for GA that they're in an uncertified residence and that they would not be able to do that next month if they came back and were recertified. Okay.
Yes. Thank you. So those are the 5 amendments. Are we ready to vote? Okay, Carrie, your turn.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover. Representative Stover is absent. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Sorry, one moment. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor. Representative Connor is absent. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan. Representative Madigan is absent. Representative Javner. Representative Javner is absent. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 9 yes, 4 absent.
So that Representative Fecto, thank you for the opportunity to wade real deep into the weeds. And hopefully we'll be helping a bunch of folks in the process.
I appreciate the committee's long discussion surrounding this. Very much appreciate it. I hope you guys have a great day.
Thank you. And we want to thank Sarah Denson for her expertise and Dr. Springle for being here and helping us out. And I'm missing somebody who was a resource before, but my brain is fried.
Allison Webb.
Oh, thank you. Yes, Ms. Webb, thank you all for your contributions. So I'm proposing a 15-minute break until we start our afternoon activities now that we've concluded our morning activities. So we'll be back to consider 3 small bills this afternoon and figure out what we want to do with them. Back at 4:30. Oh, my dog used to follow me upstairs whenever I came up here, but she gave up on me whenever I come into this room. And thank you for pointing out that we were late, Senator Moore. We otherwise wouldn't have known that.
I just couldn't resist, Senator Claxton.
I know. Fair game. Representative Griffin probably made you do it, right?
Yeah, it's all her fault.
There you go. Just picked up another bill. Main care, managed care, another small one.
Does that mean we already have the answer?
All right, we're back in session. Hopefully not too many people really listen to us on the 4:30 thing. And we'll start with LD 1603 and then do 1548 and then 1653. And figure out where we want to go with these wee small bills. All right. It being 4:30, we'll get started. So when, oh, we wore out Anna, so now it's Aaron we're beating up on.
You're on mute.
You're muted. Anna.
I'm here, but they're public hearings, so I just sit in the back and listen.
Okay, well, I just want to make sure you were there.
You're not alone. Don't worry.
All right. I'm so locked in that I was waiting for the analysis of the bill. We haven't even heard it yet. So let's start with hearing the bill.
Okay.
We'll do it that way this time. Representative Meyer, I think this is yours.
Yes, it is. Thank you, Mr. Chair, Senator Claxton, and esteemed colleagues on the Joint Standing Committee on Health and Human Services. I am Representative Michelle Meyer, in service to Southern Maine's District 2, Elliott's, and parts of Kittery and South Berwick. I'm pleased to introduce to you today LD 1603, an act to implement the recommendations of the committee to study the feasibility of creating basic income security. The 129th legislature established the committee to study the feasibility of creating basic income security. Its 11 members meeting over the interim to examine, assess, and make recommendations regarding the provision of basic economic security through a direct cash payment system. The committee learned about a number of basic income experiments, including the case studies of programs in Alaska, Mississippi, and Manitoba, demonstrating a clear correlation between a guaranteed basic income program and a reduction in poverty. As directed by the authorizing legislation, LD 1324, the committee investigated Maine's existing safety net and work support programs in its attempt to evaluate the effectiveness of what is presently available and what measures might be taken to improve on the delivery of programming in place to lift people out of poverty and create sustainable financial stability. The committee found navigating public assistance and safety net programs in our state difficult, an experience echoed by those providing testimony, describing a siloed process in need of a more integrative approach to applying, enrolling, and maintaining benefits, to reducing governmental inefficiencies, taking advantage of federal options and funds, reducing benefit cliffs, and making eligibility requirements clear and understandable. A streamlined, modern system, making our state safety net simple, easy to use, well coordinated, and efficient. Section 1 of the bill recognizes this need for a top-down government solution to move toward bringing our systems into the 21st century and creates a new committee within the Governor's Office of Policy, Innovation, and the Future to move this type of systems reform forward. Section 2 reestablishes the committee to study the feasibility of creating basic income security to continue the work that a truncated timeframe for meeting did not allow. The potential for a special session in the spring and summer of 2020 delayed the start of the study committee reconvening in the interim and did not allow for a full evaluation of all the committee was charged with. The reestablished committee would be given the authority to contract with an outside consultant utilizing private sector funding to conduct an economic feasibility study of providing basic income to Maine residents and would report back to the Joint Standing Committee on Labor and Housing. Basic income security has gained worldwide attention since the start of the pandemic. Over the course of the last 14 months, both the Trump and Biden administrations have moved to help mitigate the financial burden resultant of COVID-19 by providing direct economic assistance to our nation's workers, families, and small businesses. Most Americans have received several stimulus payments to boost the economic health of their household finances and that of our economy. These payments are a real-time experiment in basic income security. It's an idea worth exploring further. I thank you for your consideration, and I'd be happy to answer any questions.
Thank you for bringing up LD 1603. Are there any questions of our Representative Meyer? I don't see any. I understand there are folks here to speak in support, and we'll begin with Ann Danforth. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Committee on Health and Human Services. My name is Ann Danforth, and I'm a policy advocate at Maine Equal Justice. We are a civil legal services organization working with and for people with low income, seeking solutions to poverty through policy, education, and legal representation. While Maine Equal Justice supports Section 2 of this bill, I will focus my testimony today on our support of Section 1, which would help modernize and improve our current safety net and work support programs, moving us toward a system that, as Representative Meyer described, is simple and easy to use, well-coordinated, human-centered, and efficient. At Maine Equal Justice, we hear from clients regularly about the challenges they face trying to access safety net and work support programs from a system that is siloed, antiquated, and inefficient. The administrative responsibility to deliver the help people need is scattered throughout different governmental agencies and is largely not integrated or coordinated. While these supports are essential, they aren't reaching many of those who need them most. We have the opportunity now to begin to change this. And at a time when 1 out of 3 Mainers are reporting difficulty covering usual household expenses, and with our post-pandemic economic recovery dependent on supporting, training, and retraining workers, it is critical that we do so. These changes will reduce governmental inefficiencies, improve people's well-being, and improve the state's economy. While there are some areas where increased coordination across state government is already being considered, it is moving in piecemeal, awkward fashion and desperately in need of encouragement, structure, and direction from the highest level of state government. I'll highlight just one example of the potential for this type of coordination, but in the written testimony I submitted, there are additional examples in realms ranging from childcare to unemployment insurance to school meals. Only about 28% of eligible low-income renters are receiving the property tax fairness credit, a refundable tax credit administered by Maine Revenue Services. Many of the people eligible for this tax credit regularly interact with DHHS, and DHHS has much of the information it needs about their potential eligibility for this tax credit. DHHS could be referring many of these eligible clients to connect them with supports across state agencies. Moving this work forward will improve people's well-being, an important goal in its own right, and it will also make our economy stronger, as recognized in the 10-year Economic Development Plan in the report of the Governor's Economic Recovery Committee. And now is the moment to prioritize this work, as many workers will be seeking employment or re-employment following COVID-19 and will need training and supports to help them in those efforts. Thank you for the opportunity to testify in support of this bill, and I'm happy to answer any questions that I'm able to.
Thank you. Are there any questions of Ann Danforth? I'm not seeing any, so thank you for coming out. Sorry we were delayed getting here. And we're also going to hear from Larry Danziger. You want to unmute and join us?
Yes, I hope I'm unmuted now.
You are.
All right. I would like to say initially that I live in Bangor, by the way, and I've been involved with promoting ideas around universal basic income because I see that as a real solution to addressing issues of poverty as opposed to mitigation. So to me, this is a huge bill, not a small bill at all. This is very important in solving a problem rather than just dealing and struggling with it. So I want to emphasize that. The idea of providing direct cash benefits to people is something that's more than 50 years old. It was initiated especially in the late 1960s. The reason it was not implemented then is because of misunderstandings about the nature of poverty that have been demonstrated to be false since then, especially more recently as a result of a number of pilot projects where people are taking money, using it to benefit themselves, to address issues of poverty, to go out and get jobs, not to not work, but rather to use it to get work, for example, and to pay bills and to use it in beneficial ways. People do know themselves what to do with money, including the stimulus checks that they've recently gotten in many cases. I also want to just mention briefly several things that I did discuss a little bit with bill sponsors, or at least presented ideas to them, focusing on the reestablishment of the Basic Income Security Committee for one. Also, a couple of other questions I had is whether or not there is actually enough time to raise funds to do a privately funded study within 1 year, or less than 1 year, really. We're talking about the beginning of December. If there is an additional year that could be included in the legislation to specifically raise funds for and do that independent study, that would be very helpful. Other than that, I think what we can do in a short period of time between now and the beginning of December is to collect information from numerous pilots that have been done around the country and even outside the US as well, and to present, have the committee present that as a partial report of the benefits of direct cash benefits and payments. If there is something that can be included that adds that extra year for a locally in the state produced study, that would be beneficial as well. So I
30
hope
seconds, sir.
they will consider that as well. And the last small item is I questioned whether or not the Labor and Housing Committee is the best place to present the study itself and the legislation, when in fact this committee right now is considering it. So maybe there may be very good reasons for Labor and Housing, but not necessarily. This committee could consider that as well. That's all I have to say right now. Thanks.
Thank you, Mr. Danziger. Are there any questions? Then I'll apologize. I should not have been flippant or sarcastic. I certainly understand these to be very large and important bills, not small bills, but that's code for, oh boy, we have a whole lot of more work to do. So
Well, you don't have as complicated a situation with these bills right now. or the number of people who may have been involved in it. I understand that.
Yeah, I just thought, I want to make sure you understood that I wasn't being disrespectful.
Sure, I did.
Okay. Any other comments, questions of Mr. Danziger? I don't see any, so thank you for being here and for your work along the way. I don't see anyone else signed up to testify either for, against, or neither for nor against. So that'll conclude the public hearing portion of LD 1603. Are there any questions that we would like to address to Aaron in anticipation of our work session? And you should probably introduce yourself since you weren't here this morning when we started.
Good afternoon. My name is Erin Dooling. I'm one of the legislative analysts with the Office of Policy and Legal Analysis.
I don't see anybody with questions. Or yes, Representative Senator Moore. You keep moving us around the screen on me. Senator Moore.
Thank you, Senator Claxton. I have all kinds of titles I haven't been before. I do know that there was a published copy of the recommendations of the committee. So I don't know if we want to make sure that each member of the committee has a copy of it. You know, that might be something. I know I've got my copy, but I wasn't sure if anybody else did too. So
I think there's a hot link in my testimony.
Did you? Okay. All right. Perfect. Yep. I see it right there. All righty. Good.
Representative Perry.
Yeah, I just have a question. You said this had come as a bill before and that there was a committee that studied that. Did that come to Health and Human Services or was this to another?
Labor. Went to labor. Yeah. That they heard the authorizing legislation for the committee.
Okay, so we're looking to reauthorize the committee as well. Right?
And the report back would go to labor, who started. Yeah.
I don't see any other comments. So that'll conclude our work with LD 1603 this afternoon, and we can move on to a discussion of LD 1548. And Representative Talbot Ross will be presenting that one. We see you as unmuted, Representative Talbot Ross, and we see an R. And now there you go. Now you're unmuted. Welcome. Representative Ross, is your video looks like it's frozen.
Here.
Yeah, and we can't understand you, so you may need to kill the video. If you can turn off
Do you see me now? I've got
yes,
problems with my internet.
Yes, and it may be helped by turning off the video. There we go. Let's try that.
Hi, Senator Claxton. Hi, thank you very much. I've got problems.
Yeah, this is pretty hard to understand, Representative Ross, even with your video gone. Do you want to try dialing back in?
Internet keeps going in and out, so I may freeze. And yep.
That's better. That was better for a minute. So this will help fulfill our technical difficulties quota for the day. We'll give the representative a chance to call back in, or maybe that's the way to go. Maybe if she called in. Hello there, Representative Ross, again.
Hi, Senator. Can you hear me now?
So much better.
Thank you for your patience. I apologize for the spotty internet, but thank you all. So Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services, my name is Rachel Talbot Ross. I represent House District 40, which includes the Portland neighborhoods of Parkside, Bayside, East Bayside, Oakdale, and the University of Southern Maine campus. Thank you for the opportunity to present LD 1548, an act to alleviate the disproportionate impact of COVID-19 and public health outcomes. Throughout the COVID-19 pandemic, Maine has made headlines, largely for its leadership. We have been proactive about protecting ourselves and each other, and although the pandemic has had devastating effects here, just as in other states, we have also had some inspiring moments. At various times, we have led the nation in the rate of fully vaccinated residents and had the country's lowest infection rate. We have worked hard to keep our population as safe as possible and to ensure our healthcare workers have what they need. The news, however, has not always been positive. Members of the committee may recall last summer when COVID-19 cases were climbing in Maine, that a disturbing headline read that Maine has the widest coronavirus racial disparity gap in the country. In June 2020, more than 1 in 4 Mainers with COVID-19 were Black African American. That is, despite making up only 1.6% of the population in this, the widest state in the nation. While the disparity has decreased since then, Black African American Mainers are still much more likely to get COVID-19 than our white neighbors. In so many ways, the novel coronavirus has compelled us to see old inequities through a new lens. We have seen that this disease will exploit any weakness it finds in our society. That includes the deep cracks in our healthcare and public health systems that have long divided us by race and led to disproportionate poor health outcomes for Black, Indigenous, and people of color when compared to white people of otherwise similar circumstances. To say this another way, Black African Americans experience poorer health outcomes than white Americans, even when we adjust for factors like socioeconomic status. COVID-19 is just the latest expression of this fact. So to be clear, Maine is not unique in this. That is why the federal government has allocated funds specifically to address disproportionate health outcomes for historically disadvantaged racial communities, including by increasing equity in COVID-19. The intention of this legislation has been to ensure the funds we receive are used to address the underlying imbalances of power that have perpetuated this disproportionate outcomes. That has not changed, but I have continued to work with the Department of Health and Human Services, as well as stakeholders, to determine how we can get there. Today, I am proposing an amendment that reflects this ongoing work. The amendment would direct the department to work with the Permanent Commission on the Status of Racial, Indigenous, and Tribal Populations in order to determine the levels of funding needed to build the community-based infrastructure so that communities not only have the capacity for self-directed care, but they can become equal partners with the state in reaching overall health equity goals. We must move forward with an equity in the partnership between the community and the state. The department's establishment and support for an Office of Population Health Equity is just one side of that necessary equation to fully address health disparities and systemic inequity. It's a good step forward, but it's only one side of the equation. This bill addresses the other side of the equation, which is equipping and welcoming the communities as full partners in the solution. So this bill addresses that other side of the equation that we must invest in. To get there, we need to ask ourselves a series of questions. How much federal funding for public health and healthcare have we received and will we receive overall? How much of that funding is meant or was meant to address racial disparities? How much of that funding has already gone towards this goal? And is there any portion of these funds intended to be used as direct investments in the public health infrastructure within these communities? And lastly, are there any existing programs independent of COVID relief funding that aim to target racial health disparities? The amendment also directs the Department and Commission to report back to this committee by January 15th, 2020 with its findings. This gives them the time they need to consider these questions while also allowing the legislature to put the results of the process to good use during the second regular session. I would be remiss if I did not explicitly address why building up the community-based infrastructure is so necessary. As important as the department's efforts and establishment of the new office are, these are empty promises without full partnerships within the communities. Without empowering community partnerships, the investments we do make will not result in meaningful, sustained improvements, and the structural inequities that underlie racial health disparities will continue without disruption. The trajectory of systemic inequity has had many years, in fact, centuries, to produce the devastating consequences we see today. We can bend that trajectory, but it will take intentional action to address the imbalance of power that has long maintained its course. In terms of public health outcomes, we can begin that work today with LD 1548. I know you've had an extraordinarily long day, so I'd be happy to answer any questions that you would have, and I thank you for your attention and the flexibility you've had with my testimony today. Thank you, Senator.
Thank you, Representative Talbot Ross. Are there any questions of the representative? Yes, Senator Moore.
Thank you, Senator Claxton. Thank you, Representative Rachel Ross. We missed you on the committee here, I'll tell you. Just one real quick question. I know that Senator Keim has a bill in that is establishing a COVID commission that I believe is going to be taking a look at all angles of what happened, the money, where it's going, what's been done in the past, and so forth. Do you think that that commission might be a spot that could also incorporate some of these concerns that you've brought forth?
Well, thank you, Senator, for the question. My answer would be yes and no. Yes, is because I do think we have to look at this issue in an integrated manner so that if there is this COVID commission, then there could be membership from these communities to participate, again, in an integrated process and exploration. So that's yes. The reason why I would also offer no is because a lot of this work isn't as successful when we're one seat or two seats at a table and are not helping to lead the work. So it's really important to have that agency to lead this work. So I think it's a both and, not an either or, Senator.
Thank you. I appreciate that.
Any other questions of the representative? I don't see any. Thank you for the challenge, for fighting through the challenges of getting your testimony in.
Thank you all very, very much.
Next, we're going to hear from Kathy Kilrain Del Rio. Welcome.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, members of the Health and Human Services Committee. My name is Kathy Kilrain Del Rio. I use she, her pronouns, and I'm the Director of Campaigns and Healthcare Advocacy for Maine Equal Justice, a nonprofit legal aid provider working with low-income Mainers to increase economic security, opportunity, and equity for people in Maine. Today, I'm supporting LD 1548. We've talked many times this year about the disparities Mainers of color, especially Black and African American Mainers, have experienced due to COVID-19 and inequities in our healthcare system, and really in multiple systems that impact the social determinants of health. I'm not going to go into all that data because I know you had a long day, and also I know you've had it before you in many pieces of testimony today and all session. In preparing to testify on this bill, I did some additional research about racial equity and what do we mean when we say that and why does it matter? Representative Talbot Ross and many others have shared their thoughts about this today and in testimony on many other vital bills. What could I really add to that, to their eloquent words? In my research, I came across a description from Race Forward that really resonated with me in the context of the bill before you. Race Forward is a nonprofit that is recognized nationally as a leader in racial justice, working with communities, organizations, and sectors to build strategies to advance racial justice in our policies, institutions, and culture. They define racial equity as both an outcome and a process. As an outcome, we achieve racial equity when race no longer determines one's socioeconomic outcomes, when everyone has what they need to thrive, no matter where they live. As a process, we apply racial equity when those most impacted by structural racial inequity are meaningfully involved in the creation and implementation of the institutional policies and practices that impact their lives. That's just what LD 1548 aims to achieve, both the outcome of health equity for historically racially disadvantaged populations and a process that centers the experience and expertise of people from those communities who know best how to address the disparities they live with every day. Without an equitable process that shifts the way we invest in communities that experience disparities, we will never achieve real equity and will continue to see Black, Brown, and Indigenous Mainers suffer worse health outcomes, bear the brunt of this pandemic and any future viral outbreaks, and live shorter lives than their white neighbors. In guidance released yesterday from the Treasury about the use of the ARP funds, they noted that while the pandemic has affected communities across the country, it has disproportionately impacted low-income families and communities of color and has exacerbated systemic health and economic inequities. Therefore, they allow for a broad range of uses to address the disproportionate public health and economic impacts of the crisis on the hardest hit communities, populations, and households. Maine should have a plan to use an adequate portion of these funds and any future federal funding related to the pandemic to make investments to support the public health infrastructure of communities of color. And the development of that plan must be transparent and guided by the people who have the greatest expertise about those communities, people from and organizations deeply rooted in those communities. And I'll just note that at Maine Equal Justice, we have the honor to work with people who are directly impacted, who are Black and Brown Mainers, or who are in those organizations that work with those communities all the time. And we've repeatedly heard how frustrating it is to be brought into a discussion with DHHS or other state government agencies to implement a program or plan meant to serve their communities after all the decisions have already been made. That's why LD 1548 really makes such a difference. For all these reasons, I urge you to support that bill, and I'm happy to answer any questions you have.
Thank you for your testimony. I'm looking to see if there's any questions. I'm not seeing any. So again, thank you for being here. I'm not aware of anybody else who wants to testify for, against, or neither for nor against. So that'll conclude the public hearing portion of LD 1548. Any questions that we would like to direct to Aaron for our work session effort? I'm not seeing any. So we'll move on for consideration of LD 1653. We have a couple people here to speak to it. And the question is whether you want to introduce it at all, Representative Meyer?
Sure. Thank you, Mr. Chair. I will simply say that I am Representative Michelle Meyer, proudly serving Southern Maine's House District 2. I was asked to sponsor this bill at the request of the department, and so I introduced to you LD 1653, resolve regarding legislative review of Chapter 124, Emergency Medical Services Personnel Reporting Rule, a late filed major substantive rule of the DHHS, Maine CDC, and prevention. And I will turn the mic over to Mr. Sam Hurley.
Welcome, Mr. Hurley, if you want to unmute and join us.
Good afternoon, Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee of Health and Human Services. My name is Sam Hurley, and I'm the Director of Maine Emergency Medical Services, or Maine EMS, within the Department of Public Safety. I am testifying on behalf of the Maine Department of Public Safety and Maine EMS in support of LD 1653. At the beginning of the COVID-19 pandemic in the state of Maine, Maine EMS and the Maine CDC identified a need to be able to identify EMS clinicians and emergency medical dispatchers throughout the state that were affected by the virus. This was prudent to understand the impacts of on our staffing and our system's capability and capacity to maintain continued response to medical emergencies, COVID-19 related and not, throughout our state. This tool, as implemented in these rules, is able to capture information about EMS clinicians and emergency medical dispatchers that initiate quarantine, complete quarantine, exhibit signs or symptoms consistent with infectious disease, are tested for the disease, are confirmed positive cases of the disease, are admitted to the hospital for the disease, die from the disease, and those who return to work following infection from the disease. The rules language is developed collaboratively from my office and Maine CDC to ensure that the provision could be used again in the future should we ever be faced again with another public health emergency of similar magnitude. Since its implementation in April of 2020, there have been reports regarding 507 different EMS clinicians and emergency medical dispatchers that have been affected by COVID-19 disease in the state of Maine. This doesn't mean that all 507 individuals developed COVID, but they were affected in some way. For example, they were either exposed, they developed some sign or symptom that was consistent with it, they completed a quarantine, they were tested, they had a positive test result, or they returned to work. Using this methodology, this is how we notify agencies and reach out to agencies and guide them through the process of quarantine guidance for EMS agencies and other technical guidance, technical epidemiological guidance. And so this tool has been instrumental in us providing support. So we appreciate your time and consideration of this bill, and we ask that you support this legislation by voting ought to pass. I'm more than happy to answer any questions you may have at this time. Please feel free to reach out to me anytime if there's any additional information that I can offer you and or the committee.
Thank you for that. Mr. Hurley, are there questions? And I'm wondering, did I see that you had submitted your materials to the website?
Yes, sir. I did submit my testimony last night, I believe. And
Yep.
I believe Tara is here from the CDC as well.
I see both of them. Thank you for that. Anything else? I don't see any other questions. So we'll next hear from Tara Perry.
Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Tara Perry, and I am the Maine Center for Disease Control and Prevention's Policy and Compliance Manager. I am here today to provide testimony on behalf of the Maine Center for Disease Control and Prevention, and will be speaking in support of LD 1653 resolve regarding legislative review of Chapter 124. This resolve provides for the legislative review of 10-144 Code of Maine Rules, Chapter 124, Emergency Medical Services Personnel Reporting Rule, a major substantive rule of the Department of Health and Human Services, Maine CDC, that was filed outside the legislative rule acceptance period. Chapter 124 permanently establishes requirements for emergency medical service organizations and emergency medical dispatch centers to monitor and report information about the status of EMS personnel who are absent from duty during an extreme public health emergency as a result of their exposure or potential exposure to a notifiable disease or condition. Reporting requirements are consistent with the rule adopted on an emergency basis on April 22nd, 2020, as well as a subsequent provisionally adopted rule before this committee. The department is authorized to implement rules related to addressing any shortage of healthcare workers in accordance with Title 22, Section 820, subsection 1C. The final adoption of this rule will assist with statewide emergency preparedness and responsiveness, providing for the continued reporting and surveillance of the capacity of Maine's emergency medical systems, specifically emergency medical service responders, medical service transporters, and dispatchers licensed by Maine Bureau of Emergency Medical Services, Maine EMS. Since the implementation of reporting requirements beginning in April of 2020, there have been reports regarding 507 different EMS personnel and emergency medical dispatchers who were affected by COVID-19. This result doesn't mean that all 507 developed COVID-19, but they were affected in some way, either exposed, developed signs or symptoms, completed quarantine, were tested, had a positive test result, and/or returned to work. If approved by the legislature, EMS organizations and EMD centers will be responsible for continuing to report certain information related to an employee's absence, ensuring the department's continued coordination and integration of activities and resources related to emergency medical services to inform the overall planning, evaluation, coordination, facilitation, and operations of an effective, comprehensive statewide emergency medical services system. In summary, the Maine CDC supports LD 1653 and respectfully recommends this resolve ought to pass to allow for the final adoption of the agency's major substantive rule that would make permanent the electronic reporting requirements introduced by emergency rule. Accurate and reliable statewide data is essential for coordinating with the municipal localities, other state offices, federal emergency management agencies, and healthcare systems across the state in order to prepare for and respond to public health emergency needs. Information collected under this rule is to be used strictly for public health purposes, serving to inform decisions regarding EMS workforce capacity as a key element of a comprehensive and effective emergency medical services system that ensures optimal patient care. Thank you for your consideration of this matter and for the opportunity to provide testimony today. The Maine CDC will be available to participate in the work session and address any questions or requests from the committee.
Thank you for your testimony. Are there any questions of our CDC representative? I don't see any. I do notice that the language for the reporting rule is in our file, as well as a rulemaking fact sheet. So I think we're all set to review the contents of what you all have been working on. I don't see any other comments or concerns, so that'll conclude the public hearing portion of LD 1653. And then we'll ask if anybody has any additional data or information they'd like to have from Aaron. Not seeing any. I will check in with Aaron to make sure we're still planning to do a chairs and leads Tuesday gathering. So
Yes, I hope it's not very long, but I think we should just check in.
yeah, me too. And yes. Okay. All right. You're all set with that, Senator Moore and Representative Griffin. Okay. So at this point, it being the end of a long day, or almost the end of a long day, I suggest that we adjourn until 10 o'clock tomorrow morning, at which point we will resume discussion of some work session items. Thank you all for being here. Thanks for the work. See you in the morning.